started. I'll start with the today's multi-specialty webinar. I welcome all the delegates, and I'll tell Dr. Anil Awad to kindly give his presidential address.
Yeah. Thank you, Dr. Kajal. Good morning, everyone. At the outset, I thank everyone who has come, joined this webinar today morning. It's a cool morning, and I expect more people to join in a few minutes. Today we have got a multi-specialty webinar in a real sense, because we have a variety of speakers, variety of topics. We have transplantation, we have liver, we have skin. For the first time after a long time, we are having a lecture on skin today. And of course, not to forget our Dr. Pardawala, who will be talking about how to differentiate between different types of fevers. So do attend this webinar. It's going to be a very wonderful and very informative webinar today. Friends, we have got another webinar coming up on this Tuesday. It's a very small webinar, and it is in the afternoons from 2:50 to say around 4:30. It's on allergic rhinitis, and the link for that registration and the joining will be sent to you after the moment this webinar gets over, because we didn't want to, confuse you people. So the link will be sent to you maybe by 3 o'clock today. So do join that webinar. Again, it's a good thing because you all are interested in credit points, and along with getting credit points, you get a lot of knowledge also sitting at home. So don't forget to attend both these webinars. I mean, the webinar which is coming up on Tuesday, that is the 29th of November. We have got a very big CME coming up, which is a physical CME on 4th of December. It is on the occasion of World AIDS Day. We have got 3 lectures on HIV by 3 eminent speakers, eminent personalities in the field who are working in the field of HIV. They are from the MDAC. And few more lectures are there which will be pertaining to some other topics like oncology and all those things. It's a physical CME, and don't miss this CME. Again, we are expecting 2 credit points. We have not received the credit point as yet, but we are expecting 2 credit points. And again, remember that now onwards, you are supposed to make credit point for physical CME as well. And so don't just rely on webinars. So do attend this physical CME also on 4th of December. With that, I conclude my presidential address. I request Dr. Girish Lad, are you going to talk? I request Dr. Girish Lad, who is the honorary secretary.
Everyone a pleasant Sunday morning.
Yeah.
Yeah, you can proceed.
I'll start.
Yeah, I request Kajal Ahuja to proceed with the CME webinar.
Okay, to start the session, I'll request our convener, Dr. Sarita Devi, to kindly introduce our first speaker of today's session, Dr. Jatin Kothari.
Yeah, good morning all. Dr. Jatin Kothari is Director of Nephrology, Chief Consultant of Renal Transplant Medicine at Nanavati Max Super Specialty Hospital. He was Consultant Nephrologist and Transplant Physician at Hinduja Hospital for more than 17 years. He is the Director of Apex Kidney Care. He completed his MBBS, MD, DM Nephrology from said GS Medical College and KEM Hospital, Mumbai, being a university topper with distinction honor in all these exams. He did fellowship in nephrology in renal transplantation from University of Toronto. He received International Transplant Observership, Massachusetts General Hospital, Boston, USA in 2009. He also received Roche Preceptorship Award in 2006 for visiting a scholarship, University of Alabama, Birmingham, USA. He received International Society of Peritoneal Dialysis Scholarship Award for training at the University of Missouri Health Sciences, Columbia, USA. He is a member of many renowned organizations like International Society of Nephrology, International Society of Peritoneal Dialysis, European Dialysis Transplant Association, and many more. He has several national and international publications to his credit. Today, he will speak on kidney transplantation and optimal approach for ESRD. Welcome, sir.
Good morning, all. Thank you, Dr. Sarita, for your kind words. Today's topic for the CME is to discuss about management of patients with CKD5, and in relevance to kidney transplantation, I want to put some thoughts into all of you to understand what the value of kidney transplant is in management of patients with CKD stage 5, or as we commonly know as end-stage renal disease. These are my disclosures. This CME for the IMA is with a grant from Sanofi. I thank Sanofi for inviting me for this IMA lecture. So my topic is going to be in the following format. I will discuss a little bit about what is the status of end-stage renal disease globally and also in India. What are the current numbers, etc., and what we are currently doing and what needs to be done to improve the outcomes of patients who have end-stage renal disease. In special relation, I will be talking about kidney transplant, how that option is better than dialysis. Most of us are aware that kidney transplant is definitely better, but how we can improve the numbers is what we will discuss in the next few minutes. And of course, last but not the least, look at the patient's perspective. When somebody has CKD stage 5, how does he look at the options of renal replacement therapy and how we can help him to achieve that goal of being free from dialysis? So this is data from the United States. This was published only this year, looking at the overall CKD scenario across the world. By the year 2040, it's thought that renal failure or CKD stage 5 or advanced CKD will be the 5th largest cause of death in population worldwide. It is also thought that 1 in 10 individuals across the world will have some form of CKD. And we are all aware of the common risk factors for development of CKD. We know that diabetes and hypertension are the commonest risk factors for development of CKD. There are also some ethnic differences, racial differences, where somehow Asians are more preponderant in terms of developing CKD if they are diabetic or hypertensive. We also have data from global studies saying that women are slightly higher in terms of overall incidence and prevalence of CKD compared to men, if you look at the percentage. And of course, the elderly population, more than 65, usually there are other risk factors which leads to a higher incidence of CKD. So bottom line is that this is a global problem and India is not averse to that. Just to give you some numbers and background, CKD prevalence in India is roughly about 800 per million population. And as I said earlier, the most commonest cause of CKD in our part of the world also is diabetic nephropathy. There was the CKD registry, which was started by Dr. Mohan Rajapurkar from Nadiyad, which had data from all across the country, looking at close to 1 lakh patients. And if you looked at the causes of CKD, diabetes was, yes, the commonest cause. Initially, it was thought that in our part of the world, diabetes is probably not as common, but that's not really true. Now we are clearly seeing higher and higher patients, a higher number of patients who develop diabetic kidney disease. And as a result of progression of CKD, some of them do land up with end-stage renal disease. And the overall ESRD prevalence, if you were to look at, is 150 to 200 per million population. So that means that more than 5 lakh people across India are on dialysis as a life support. And what are the other options that we can offer these patients? Kidney transplant obviously is well established now compared to all other organ transplants. Kidney transplants have been done across the world for more than 60 years now, and it is the treatment of choice for all patients with end-stage renal disease. If patients don't have an avenue for kidney transplant, as we commonly know, patients remain on dialysis. Either they can be on peritoneal dialysis or hemodialysis. And unfortunately, in our country, 65 to 70%, and this is a startling fact which I want all of you to recognize, that 65 to 70% of patients who start dialysis within 3 months have no resources, no finance to continue dialysis. So only about 30% of patients continue dialysis beyond 3 months, which clearly tells us that dialysis does not seem to be the solution for our large population of end-stage renal disease in India. Unfortunately, if patients can't afford dialysis or have no access to dialysis, they remain on some form of conservative treatment till they can go along and try and live as healthy as possible with things like diet, conservative management, etc. But that obviously is not the optimal outcome. It doesn't give you the optimal outcome if you are a patient of CKD. So we are all aware that these are the various options that are available for all patients who have CKD stage 5. As I said, dialysis is probably the commonest modality of renal replacement therapy in India. And unfortunately, because of non-eligibility of the recipients or unwilling donors or potentially no donors in the family, lead to more and more patients remaining on dialysis. If I was to summarize in terms of comparison between hemo and PD, yes, peritoneal dialysis, if done in a timely fashion, can be used as a modality of choice for the first few years when patients develop end-stage renal disease. But over a long period, we know that from global studies and even studies from India, that peritoneal dialysis is not as efficient as hemodialysis in terms of clearance of toxins and removal of fluid. Especially if patient's urine output goes down, then peritoneal dialysis probably will not be adequate for your patient who has renal failure. Coming to hemodialysis, yes, optimally, we would want to do dialysis 3 times a week, ensure that patients don't have volume overload, their uremic clearance is good, their potassiums, phosphorus, etc. is in balance. And that's what we try and offer them by doing dialysis in a cost-effective fashion in our country. Coming to the focus of the talk, which is kidney transplantation, and I'm going to spend a few minutes talking to you about the basics of kidney transplant. I know this audience is predominantly physicians, so all of you need to be aware that the only ways that we can offer kidney transplant to our patients who have end-stage renal disease is by having a donor. How does the donor come into the picture? Yes, in India, more than 90% of kidney donations happen from living donors. So if the patient is lucky, he has a blood group compatible donor in his family who comes forward, is evaluated medically, socially, and psychologically. And if he is deemed fit to be a donor, then he could potentially donate one of his kidneys to his relative and get a transplant. The other option, unfortunately, which is not very common in India, is the deceased donor or the cadaver transplant. Yes, we have made a lot of strides in the last 30 years in terms of having better cadaver donation rates. Maharashtra, fortunately or unfortunately, is amongst the top 3 states which has a high incidence of cadaver donation. And we are trying to help more and more people with kidney failure to avail of this option. As I will show you in the further slides, the disease donation may not have the optimal outcomes when you compare it to living donor, but it is still way, way better than having to remain on dialysis. Very few percentage of patients, and this is where I think as a primary physician or a family physician, your role comes in, of counseling people for what we call as preemptive transplant. When you are following these patients of CKD and you know that he is going to progress to end-stage renal disease, probably the evaluation for a transplant donor should start at least a year before he eventually gets a transplant. And ideally, we would want all our patients not to go on dialysis at all and just go for a transplant directly. That would be the best option for these patients. And that's what is called as preemptive transplant. When a patient undergoes transplant without doing any dialysis, there is a huge advantage. It doesn't deal with all the morbidities associated with dialysis, and the outcomes are really much better compared to the other options of kidney transplant. Looking at the overall survival, and this is probably the most important question which every patient and donor asks me when he comes to see me for a transplant scenario discussion. And these are the questions that they will ask you also as a family doctor, as a physician. You also need to know that overall the transplant outcomes have improved dramatically all across India. And with the better immunosuppressive strategies and better immunosuppressive medications, especially the generic transplant medications that have been available in India, has helped us to offer the transplant option to a lot many more patients who can have a better survival after transplant. If on an average you would compare dialysis outcomes and transplant outcomes, it is fair to say that the patient who has a successful kidney transplant will live at least 10 years more and obviously having a better quality of life than remaining on dialysis. If you compare the outcomes of the cadaver transplant versus the living donor transplant, Yes, this is data from a few years back, which looked at the average survival of the transplant recipients. So the average survival of transplant recipients when they get a cadaver kidney is about 9 years. And in an average living donor situation where transplant is done, the survival is more than 16 years. So you can see that more availability of living donors and potentially how we can add on to more living donors in the family is what we will discuss in the next few slides. Unfortunately, we all know that the supply of the organs is much less than the demand. There is a big disparity between the availability and the requirement of transplant kidneys and all other organs. Incompatibility of blood group and also the HLA mismatch with donor-specific antibodies could also be a hindrance for transplant in some cases. And that's what we are trying to address by having the swap program. The swap program essentially is a paired kidney exchange program, which we have started in Mumbai and Maharashtra for the last 10 years. It is a simple matchmaking agency. We run this registry called the Apex Swap Transplant Registry, where we register all patients who have a living donor in their family. But for blood group incompatibility, say a patient has blood group B and his willing donor has a blood group of A. That A donor ideally should not donate to the B recipient. So in the swap registry, what we do is we register all these patients and then offer them a matchmaking process where the B donor will give a kidney to a B recipient and in exchange get a kidney from the A donor, which can be put into the A recipient. And that's what essentially paired donation means. Paired donation has been done all across the world over the last 30 to 35 years with tremendous success. It is important for you to understand that the paired donation helps both the pairs. It is not unidirectional. It should not be that one of the pairs benefits and the other pair doesn't benefit. There has to be no financial transaction in terms of exchange of these kidneys between the two pairs. So all these things are within the legal purview of the Human Organ Transplantation Act in India. And since the year 2014, our Transplantation Act has also been amended where swap transplant is officially included as a legally accepted option for kidney transplantation. So this is something that we have tried to focus on. As of date, we've had more than 450 patients register with the Apex Swap Transplant Registry. These patients come from public hospitals, private hospitals. We've had patients who come from out of state, and all these patients are registered. They are evaluated by their respective nephrologist and transplant surgeon. And we offer them the option of giving them a paired kidney, and the transplant would be done at the respective centers wherever the patient is registered. So kidney transplantation, as we can see, is recommended to all patients with CKD stage 5 who are expected to reach end-stage renal disease soon. Potentially, as I mentioned earlier, we should start the evaluation for transplantation at least 6 to 12 months before the anticipated initiation of dialysis. All potential candidates already on dialysis who are medically stable and where we know that they are not going to recover kidney function should be evaluated with all possible options for kidney donation from their family members or at least registered for the deceased donor or the cadaver transplant program. The current law of Maharashtra states that they can register at one private hospital and one public hospital anywhere in the state. The Zonal Transplant Coordination Center in Mumbai, and there are 4 more zonal transplant coordination centers across Maharashtra, which are located in Pune, Nagpur, Aurangabad, and I'm told Nashik is also going to soon have a ZTCC, which will allocate all the organs that are available in those areas of the state. And there is an exchange program where we can exchange the kidneys from different states or different places across a state also. As I said, preemptive transplant would be the ideal, but the real world scenario is that hardly 1% of our patients eventually have a preemptive transplant. Most patients would wait, go on dialysis, have a few months on dialysis, and then decide whether they want to go ahead with a transplant or not. Coming to kidney transplantation, we need to assess what is the suitability. So it is very important for all of us to know that all patients with end-stage renal disease may not be suitable candidates for transplantation. So what is the inclusion criteria? Which are the patients where you would avoid doing a transplant? Because transplant entitles the patients to get heavy doses of immunosuppressive medications. Some of them have to be continued lifelong. there is a significant element of risk in the first 90 days when the immunosuppressive drugs are at a high dose. So patients who have significant cardiac or respiratory problems, patients who have an active malignancy, patients who have chronic infections, especially HIV and hepatitis C. Fortunately, hepatitis C and HIV is now treatable, and most of our patients take the antiviral treatment. And if their viral load becomes negative, they may be eligible for a transplant down the line. Patients who have severe peripheral vascular disease or who have morbid obesity with a BMI of more than 40 sometimes are not considered for transplant just because of the technical issues and the problems of doing the transplant. So overall, if you look at all patients who require a kidney transplant, more or less than 40% of patients who are on dialysis will eventually be deemed suitable to have a kidney transplant. Now, once they are deemed suitable, the search is on for potential donors from the family. And these are the limiting factors for how family donors traditionally would get rejected. As I said earlier, if the blood group is not matching, earlier before the swap programs, these donors were rejected. If they had an HLA mismatch and for some reason, if the recipient has donor-specific antibodies, some of the times these donors were also rejected. But now with the advent of swap and even with desensitization protocol and ABO incompatible transplant, which has also been started in a few centers across India, this option of going across the blood group and across tissue typing has also offered more patients to go forward with the transplant option. As we said, all patients who eventually go for a transplant have to have an HLA typing and a lymphocyte cross-match. This is mandatorily done between the donor lymphocytes and the patient's serum. The cross-match test has to be favorable. The cross-match test is done by 3 methodologies. In the interest of time, I would just say that the cross-match has to be negative before they proceed for a transplant. Now, the obvious question is that I've been talking about transplant, but really, how much benefit do these patients have? We did see that they have a survival benefit. At the same time, their overall quality of life also improves remarkably after a successful transplant. You can imagine that somebody who's on dialysis 3 times a week, doing 3.5 to 4 hours every time, there is a lot of time lost for the patients who are on dialysis. Even their attendants and family members have to accompany them to the dialysis centers. Even if they are doing home dialysis, it is a cumbersome treatment. And somehow, if you are able to offer the kidney transplant as an option, this would be a much, much better output for the patients who have kidney failure. With the advent of new immunosuppressive drugs, especially new induction treatment and drugs like cyclosporin, tacrolimus, mycophenolate, the patient's outcomes after transplant has dramatically improved. Our over-dependence on steroids, and we still use steroids in most of our transplant recipients lifelong, but the steroid doses are so low. Beyond 6 months, most of these patients are only on 2.5 milligrams of prednisone. So they have to be on very low dose of steroids, which helps them to have less side effects with all these immunosuppressive drugs. This has also helped us in reducing the post-operative complications after transplantation. So, friends, it is for sure that kidney transplantation is a much, much superior option compared to dialysis. It helps the patients in terms of having lesser mortality, lesser cardiovascular outcomes, and a much, much better quality of life if they were able to go across the barriers of transplantation, as I mentioned. Overall, India is still lagging behind in terms of the number of transplants. In an absolute number, we are close to about 8,000 transplants in a year. This is second to only the United States. But for a population of 140 crores, and with an incidence of CKD stage 1 to 5 being approximately 10%, we know that we need to do many, many more transplants to get people out of dialysis and help improve their overall outcomes. This is a study from a few years back looking at the overall comparison vis-a-vis transplantation and dialysis. And you can clearly see in the blue curve that the outcomes of patients who are on dialysis, which is in the blue curve, is much poorer compared to patients who've had a successful transplant, which is shown in the green curve in the diagram. Over a period of 7 years, we clearly see that there is a big advantage of doing a transplant rather than remaining on dialysis. If you look at outcomes like cardiac events and hospitalization, again, the patients who've had a transplant have a much lesser incidence of getting admitted for volume overload and cardiac problems compared to dialysis. So clearly, patients have a better outcome. What about India? And as I've covered a few of the points, but this is data from Indian centers, and this is a paper written by Vivek Jha, which was published in JAPI a couple of years back, looking at the overall graft survival in India. So we are not that much behind compared to the Western world. If you can see, the cumulative graft survival and patient survival is comparable at 3 and 5 years to any other advanced transplant program across the world. So because of the help from the pharmaceutical industry with making of generic medications, transplantation and further post-transplant care has become much, much more manageable for a larger patient population across India. This is my last slide to end the discussion, and I would be happy to take any questions at the end of this talk. What are the current challenges of transplantation in India? Number one is the availability of donors. Number two is availability of donors. Number three is availability of donors. So the lack of donors and lack of medically suitable donors is the biggest hindrance. Awareness about cadaver transplant is very poor across India. And that's where somewhere where as a group, we have to try and create more and more awareness wherever possible in terms of promoting the legal transplant options across our country. And when I say legal, we don't want to enter into scenarios where our country and our patients get a bad name by doing unrelated or illegal transplantation. We want to promote more and more living donors from the family. We want to promote more organ donation from people who are brain dead. And also we want to promote things like swap transplant and ABO incompatible transplant, which are reasonably good options for patients who have end-stage renal disease. Sometimes our religion, our society, all these have some preconceived notions. And as a community, we have to try and address that and make sure there is no religion anywhere in the world which prevents you from donating your organs after you are dead. So that's something that we need to promote in the communities that we are working. We also have to tell the patients that these immunosuppressive drugs are much, much more easily accessible now. And that's what was a challenge a few years back. But now with the advent of generic medicines, we are happy to say that most patients can continue treatment at a very, very low cost. Yes, there are some issues with lack of registry data from our country. As far as epidemiological data goes, except for the CKD registry, there is no formal registry for CKD or formal registry for transplant outcomes. So that's something at a policy level where we have to work together and try and get these data from our country, because only after we know the extent of the problem, we'll be able to address that at various levels. At an institutional level and wherever you are working, you should try and promote more and more people coming forward as potential organ donors. Even after their death, talk about brain death, talk about organ donation after death. And that's predominantly how we will be able to reduce the challenges that we face in today, day to day, for all patients who have end-stage renal disease. I thank you for your kind attention, and I'll be happy to take any questions or comments. Thank you.
Thank you, Dr. Jatin Kothari, for the informative lecture. People are asking, what is the cost of transplant, and one is contraindications.
So contraindications, Dr. Sarita, I did cover briefly. In the interest of time, the predominant things are obviously if patient has any active infection or malignancy, that's where we would really keep the patients on hold. Sometimes, with the advent of better cancer treatments, patients go into remission. And if they remain in remission for more than 5 years, then yes, they can be considered for transplant. One of the other things which is a preconceived notion is that people beyond a certain age cannot have a transplant. So the usual cutoff was 65, but I can tell you from our experience over the last 20 years that we've transplanted even 75-year-olds, especially if they have good cardiac status, then that age is not a barrier for not going for transplant. If the patient has any active infection, yes, they should be treated for that infection, and only after that they can go ahead. Coming to cost, the cost would vary between a public hospital or a private hospital. It would depend on what is the patient's location. If for an average transplant recipient who undergoes a transplant in a private setup in Mumbai, if you were to compare, the average cost is around 6 to 8 lakhs. That's for the transplantation itself. The immunosuppressive medications would be separate depending on what protocol a particular nephrologist uses. In a public hospital, the transplant can actually be done in about 2 to 2.5 lakhs. And fortunately, with our Maharashtra state program, the MJPJY scheme, the transplantation is included in the package of the MJPJY. So they can go avail for a transplant at a public hospital which is empaneled with the MJPJY scheme.
Sir, what is the success rate?
So as I shared some of the data which I showed in the slides, overall success of transplant has dramatically improved. I would say the 5-year survival of the kidneys as well as the patients is more than 90%. And if you are looking at outcomes over a half-life, yes, the kidney half-life is roughly about 16 to 18 years. So 50% of the patients who have transplantation and who go through the initial phase of transplant in a reasonably smooth fashion, they will have a long-term survival of more than 20 years, even possible in a public hospital scenario. So transplantation outcomes have dramatically improved even in India, and all patients who are suitable for the transplantation should be considered for the transplantation.
So there's
Thank
one more question. What about patients with connective tissue disorder or who are on steroids?
So coming to steroids, Dr. Anil, it is very important for all of us to know that patients will need to take a low dose of steroid after transplantation. They cannot stop the steroids. At the same time, most of the autoimmune diseases which progress to CKD5 and end-stage renal disease, the commonest we see is lupus and sometimes rheumatoid arthritis. These patients are already on immunosuppressive medication. So per se, there is no contraindication, but we have to be aware that these patients have been on immunosuppressive even before transplantation. So we have to be careful. Their immunosuppressive strategy after the transplant may need to be modified a little bit. We want to reduce their overall exposure to immunosuppressive drugs so that the rate of infection can be controlled. But yes, all patients with connective tissue disease, as long as they don't have active lupus or active rheumatoid, can go ahead with transplantation in our country.
Thank you, sir.
Thank you, sir. Okay, thank you. The next speaker,
Thank you.
Thank you, Jatin Kothari, sir.
we go to the next.
I think this year you have come for the second time. I think you had come in the month of May also.
That's true. I'm very thankful to the IMA to giving me this opportunity, and I try and give focus on contemporary management of CKD. There are a lot of myths and facts about transplantation, and last time I think at the IMA talk I had covered some of the myths that are usually thought about, and India somehow seems to get a bad name that we have all the kidney rackets in India, but there are a lot of people who are doing a lot of good work, and transplantation should be offered in the legal framework to more and more patients across our country. So thank you for the opportunity.
Thank you, sir.
Thank you.
The second speaker for today's session is Dr. Praveen Banodkar. Dr. Praveen Banodkar is a consultant dermatologist and director and founder Skin Crest Clinic, Mumbai, and is a senior consultant dermatologist attached to Saifi, Breach Candy, St. Elizabeth, and SRCC Children's Hospital. Dr. Banodkar did his MBBS from Bharatiya Vidyapeeth Medical College and Diploma in Dermatology from the Royal College of Physicians and Surgeons, Glasgow. Dr. Banodkar has done research on epidemiology study on 1,500 pediatric dermatosis, performed over 25,000 cases of laser hair reduction, over 600 cases of fractional lasers, 20,000 cases of chemical peels and microdermabrasions, and many cases of Botox and fillers treatments. Dr. Banodkar has teaching and guiding experience to National Board Dermatology students. Dr. Banodkar has presented extensively at national and international conferences. He is on numerous national dermatology academic committees. Today, he'll be speaking to us on updates in atopic eczema. Over to Dr. Praveen Banodkar. Welcome, sir.
Thank you very much for the kind introduction. So here I would firstly like to thank Dr. Anil Awad sir for having invited me here on this prestigious platform. And I would also congratulate the team IMA Mumbai for doing such good work. You can just give me a thumbs up if you can see my presentation.
Yes,
and then
sir, we
I'll
can.
begin. Right. So I just move this down here. Okay. Yes, so good morning. So we will be speaking basically quickly on various practical points on atopic eczema, atopic dermatitis. It is one of the most common dermatology conditions that we see in a practice, which tends to affect quality of life in all age groups, from the pediatric to the geriatric age groups. I'm sorry, I just need to, I think, reshare it because it's not. Yes. So atopic dermatitis is a chronic relapsing inflammatory disease, which is characterized by eczematous skin lesions and intense pruritus. It is one of the most common conditions that we see on a day-to-day practice. There are many terminologies that are defined around atopic dermatitis, which you all may have heard in your day-to-day practice, which is atopy, atopic diathesis, atopic dermatitis, atopic eczema, endogenous eczema. Now, there is basically no major difference in these terminologies. What we need to remember is atopy is a tendency for getting atopic dermatitis along with allergic rhinitis, allergic conjunctivitis, or even acute bronchitis or bronchial asthma. The terminology given is basically atopy to that particular patient with high serum IgE levels. When it comes to atopic eczema, we are talking specifically of the inflammation of the skin. Now, epidemiology by geography, you can see that atopic dermatitis is ideally more commonly seen in the Western populations, where it is seen to the incidence of sometimes more than 20%. However, in an Indian population, it is coming up to a stage of around 5 to 10%, but it is on the rise because of a number of factors that I will discuss ahead. It is more common in childhood and adolescence. However, there are concepts of adult atopic dermatitis that are also being observed. Now, when you talk about prevalence, as we can see, around 15 to 30%, is seen around in children. It frequently starts at an early onset, with 45% of all cases being in the first 6 months of life in terms of an onset, and then 60% can, appear during the first year, while 85% of the patients tend to be seen below 5 years of age. Now, there are a number of causes that are there. However, the exact particular definitive cause is not known. It is considered to be a combination of genetic susceptibility, abnormal immune response, and epidermal barrier dysfunction. Now, the combination of the three is what results in majority of the symptoms of the dermatitis and eczema that we see in the patients. And there are a number of studies in terms of immune responses that are developing, where immune response like a Th2 response basically drives the disease process. So two most important things that one needs to know when they're dealing with atopic dermatitis, that it is not only a disrupted barrier of the skin. Now, this was a concept that was there many years ago, but now the new updated science on atopic dermatitis in terms of research has shown a very heavy immune response, a specific cytokine, a Th2 cell immune response, which is seen that causes an inflammatory imbalance in the skin and therefore is considered as an autoimmune skin disease. And we do tend to manage it with immunosuppressives, as you will see in the lecture ahead. So initially, maybe around 2 or 3 decades ago, it was just considered moisturizers as a line of treatment to manage atopic dermatitis. But now the concepts have changed, as you will see ahead. As you can see, as I mentioned, there is a Th2 cell inflammatory imbalance basically that happens. There is a raised IgE levels that are seen in every patient of atopic dermatitis. However, it is not of a diagnostic importance to do IgE level in every patient, but majority of the patients have raised serum IgE levels, and the inflammatory cascade is through this Th2 response. Now, what about food and atopic dermatitis? We have a number of, patients coming, the parents basically eliminate certain diets, like they eliminate wheat, they eliminate milk. This ideally does not have much of evidence. As pediatric dermatologists, we have seen that there is a weak evidence that is related to the practice of elimination diets. Many patients or parents come to us mentioning that they have been advised to eliminate diets that I just mentioned. However, please note that until and unless there is a direct correlation of the increase in the inflammation in the skin with that particular food, that is the only time when you need to eliminate that particular diet. You don't need to give a complete elimination diet to any patient, because there are no, not enough evidence to prove that. Probiotic supplementation in early life is definitely effective. Specific probiotic strains like lactobacillus, bifidobacterium, propionibacterium have appeared to reduce the risk of atopic dermatitis. Vitamin D, vitamin A co-deficiencies can aggravate atopic dermatitis in children, and increased salt intake may be sometimes linked to atopic dermatitis, because as you can see, salt affects allergic immune reactions and also can cause a little bit of inflammation, local irritation in the skin. Now, when it comes to systemic manifestations of atopic dermatitis, there is not much. It is more related to the other autoimmune profiles like acute asthma, acute bronchitis, acute allergic rhinitis, or allergic conjunctivitis that I've seen. Of course, there are other autoimmune disorders that you need to rule out. For example, skin-based, which include vitiligo, alopecia areata, that can be seen along with the cases. Of course, there has been even other conditions like thyroid abnormalities, more tendency to have diabetic disorders because of this autoimmune nature of the condition. So coming to the quick talk on clinical manifestations, as we can see, there is erythema, there is edema, there is vesicles, that is blister formations, is what is seen in majority of the cases. And they tend to vary in every age group. Now, when you have infants, up to 2 years of age group, the lesions of dryness, itching, irritation is commonly seen on the extensor surfaces of the extremities, which include the face, the forehead, the cheeks and chin, neck, scalp and trunk area. While in childhood, when it basically comes to childhood cases, we see more in the flexural surface of the extremities, such as elbow folds, the neck area, back of the knee area, the wrist and the ankles. And when it comes to adulthood, again, a flexural surfaces and hands and limbs are basically affected. As you can see, it is associated with different kinds of presentations where you see an inflammatory profile with a lot of erythema, redness, itching and scaling. So every case that itches, remember, is not fungal, is not an infection. It can be majority of the time just an atopic dermatitis that is causing a lot of disturbance in the quality of life of the patient. So it is associated with dry, itchy skin with rashes. Red, scaly, thick and leathery skin is seen. There are small red bumps with, sometimes fluid or oozing from them. It is not necessary that it has to be an infection or pus base. It can be just an eczematous exudate. Crusty infected lesions with Staphylococcus aureus or even herpes simplex virus infections are more common in patients suffering from atopic dermatitis. And it's very dry and there is, moisture loss because of the reduced protection or the reduced barrier function of the skin. And then there is an abnormal immune response. We also see very severe cases where you can get an entire erythrodermic picture where there is a 90% of the body surface area involvement. And in such situations, you can have a lot of, temperature abnormalities where the body temperature cannot be maintained. There is a loss of protein. It results in edema all over the body and can also result in short stature over a period of time, as I had mentioned, in very chronic atopic eczema cases. So there is this basically itch and scratch cycle that we need to break, which I will explain to you ahead. Now, when it comes to diagnosis, there are a number of criteria which are seen, where there is an intense itching, characteristic rash in typical locations, as I have mentioned. And then there are certain minor features that you need to look into, as I mentioned, about a family history, about the early age of onset, then the high IgE levels, cheilitis, eczemas, and susceptibility to skin infections. Of course, the major things that you need to see in every patient are intense itching, the characteristic rash in typical locations, the chronic recurrent occurring symptoms of dryness, itching, and inflammation in the affected areas, and a personal and family history. There is a concept where patients who are suffering from eczema have an increased susceptibility to infections, which includes Staphylococcus aureus, molluscum contagiosum virus infections, herpes simplex virus infections, where sometimes the disease can spread all over the body. There is a particular condition that we see, which is called as Kaposi's varicilliform infection, where this particular condition can be grave to the life of the patient as well, if not managed and not diagnosed early. So you have to take every case of atopic dermatitis in a serious manner and treat it accordingly. Now, there are many aggravating factors that we see, especially now in the winter season. We are getting a lot of aggravation of atopic dermatitis. But however, during the months of summer also, when there is a lot of sweat, it can cause a lot of inflammatory, itchy rashes on the trunk area, in the body folds, as I've mentioned. A lot of, in Indian tradition, the oil massages are very common. What we normally recommend or suggest is to avoid heavy oil massage in the child, because friction is one of the biggest trigger factors. We recommend to apply oil. Application of oil is not a problem until and unless there is an allergy to that particular content of oil. But the massage which is done should be done in a very careful, less frictional manner. And of course, household materials, accumulation of books, carpets, dust mites are big trigger factors. We have construction work going on everywhere in the city, as you can see. So that itself, in terms of an inhalation of cement dust, paint dust, can be an aggravating factor. Another important aggravating factors we see in children is when they play with plastic toys, clays, and a number of other slime-like toys which children play, that can aggravate eczemas around the hand and disturb the quality of life in that particular child. Children normally suffer from a lot of anxiety, especially when it comes to adolescents. When they suffer from atopic eczema, they are bullied in school. The teachers mention us to write notes to make sure that they are not infected. We have even patients who sometimes, do not get admission in schools because of chronic atopic eczema. So as I have mentioned, it affects the quality of life. It can bring about a lot of depression in the patients as well as their caretakers. They have sleepless nights. And one of the studies had shown that only cerebral palsy had a higher quality of life impact secondary to atopic dermatitis. Of course, when it comes to differential diagnosis of atopic eczema, it is very important to rule out other conditions like scabies, chronic dermatophytosis, which we see nowadays in a number of patients, infantile seborrheic dermatitis, and contact eczema. Coming to, and if any particular tests are done, remember that it is more of a clinical diagnosis. One needs an eye to diagnose, to train themselves to diagnose atopic dermatitis, because it is very important, as I mentioned, because the newer studies or updates have shown that of it being an autoimmune disease process. However, there are no particular golden standard tests done in every patient. It's more of a clinical diagnosis. There are certain scores that we use in practice called the SCORAD score, which is the most commonly used. However, this is more of a study and institutional purpose scores, and we don't follow that regularly in a day-to-day busy practice. Of course, the most important point here, which I had mentioned, is about impairment of quality of life. So we do the dermatology quality life index in very chronic severe cases. Now, when it comes to management of atopic dermatitis, it is extremely important to know of how to manage and what guidelines to do. And role of counseling. Remember that atopic dermatitis is a chronic relapsing inflammatory dermatosis by definition. So it is a condition that will keep happening every week, every 5 days in terms, or every few months in terms of a flare up, the parents get fed up, frustrated about it. So role of counseling is very important. Secondly, of both the patient as well as the caretakers, bathing, short contact baths are important, in the sense that if they bath for a longer period of time, it can aggravate atopic eczema, atopic dermatitis, and be a problem to that particular child. So bath should be around 4 to 5 minutes. A lot of moisturizer use is very important. Then parents ask me about vaccination. Now, when there is an acute flare in terms of eczema, redness, irritation, edema all over the body, we tend to postpone, the live vaccinations, because for the safety of the child. And when it comes to massages, I have already mentioned in terms of the baby oil massages for the child, it's better to avoid a lot of friction, because that much of excessive soaps and harsh detergents are also used to clean off that oil, and that can just keep worsening the atopic eczema and become more systemic in nature. Now, management basically of atopic eczema is more hierarchical, that is depending upon the symptom severity. The main principles of management include emollients for epidermal barrier repair, then trigger factors which should be avoided, as I mentioned to you earlier. For example, another important point which I tell all patients is to avoid wool directly on the skin, nylon, polyesters. These particular these clothes can also aggravate atopic eczema or dermatitis. So they have to wear a cotton first, then followed by these other clothes in the child or in the adults. Then dietary changes, only directly the particular foods that are practically affecting that particular individual should be avoided. There is no need to give a blanket no to any particular diet. And of course, when it comes to topical corticosteroids, calcium inhibitors, I will explain in the slides ahead. So as you can see in this pyramid that is drawn, mild transient atopic dermatitis, topical corticosteroids remain the drug of choice. However, please remember that it should not be used and abused by the particular patient, in especially the fold areas, which include the groin, the elbow area or thigh, because it can cause a lot of side effects when used chronically. So you have to use it sparingly, judiciously, in the right manner. Then when it comes to very severe persistent atopic dermatitis, there is a role of systemic immunosuppressives, which range from cyclosporine to mycophenolate mofetil, short courses of oral prednisolone, as I will explain to you ahead. There is this concept of fingertip unit, that is from your fingertip to your first crease, that is called as a fingertip unit. Now, each fingertip unit is approximately 0.5 grams, and every tube that comes is a 30-gram tube or a 60-gram tube when it comes to a topical corticosteroid. So the fingertip unit prevents the abuse or the excessive use of topical corticosteroid, and also the right dose, which can be, because we have patients who we write certain tubes and they finish it in one day and they come back to us. You have to remember that just like you take pills or tablets, a fingertip unit is the right way of using, which is never actually followed in practice. So as family practitioners, you need to read up and know about this fingertip unit so that they can use it judiciously and it can work very economically for the patient as well. And it also, of course, prevents overdosing of that particular steroid. When it comes to bathing, washing, and emollients, I have already mentioned to you about the short baths, avoiding use of soaps, detergents, bubble baths. Preferably, patients should also avoid shower baths, because in a shower, which is a handheld shower, the water hits at the skin at a very fast speed and causes more exfoliation and dryness of the skin and can aggravate atopic eczemas. Emollients or moisturizers should be used liberally, preferably on damp skin, and should be used every 2 to 3 hours if possible. If it is not practical, patients can just maintain a morning, afternoon, and evening application routine. Then when it comes to moisturizers, remember there are different kinds of moisturizers. There are different types, we call them as humectants. They are like sponges. They absorb water into the skin, the moisture into the skin, not water. They absorb moisture into the skin. Emollients, which help in filling the small gap between the skin cells. And then there are ceramides, which are basically a kind of repairing the barrier, which I mentioned to you, that causes the transepidermal or the water loss that is happening. It seals it. And then there are occlusives, like you may have heard of Vaseline petrolatum jelly or coconut oil, which basically work in terms of just sealing up a skin, like a glass kept on the table, like occlusives. So remember, moisturizers is not just a moisturizer. There are different types, and when used smartly and intellectually, understanding the what moisturizers to use in what particular condition, you can go a long way in controlling the flare-ups in eczema cases. Now coming to the next slide about the dose of emollient. Ideally, what dose is mentioned is around 250 grams of emollient should be applied per week in the very severe cases. So, but that may not be practical in all the patient when it comes to the costing. So there is this concept of ceramides in moisturizers. There are certain ceramide dominant moisturizers that reduce the severity. So remember, what is a ceramide? Ceramide is like cement in the wall. It basically helps in gluing up or fixing the barrier damage which happens in atopic dermatitis. So it can be used as a monotherapy in particular cases, like for example, around vulnerable areas like around the eyelid, maybe in children, or in the body fold areas where steroids can have a long-term side effects. So there are certain guideline, recommendations where daily moisturization, as I just mentioned, is the bedrock of atopic dermatitis management. It is recommended in all the national and international guidelines. So 2 to 3 times a day is what is recommended by the Skin Allergy Society of India, and basically overall improves the quality of life of the patient. Now, there are the newer kind of methods of treatment of atopic eczema to prevent the flare, which include proactive therapy. Proactive therapy means this is basically a concept where a patient gets a flare, acute red inflammatory patches onto the skin, and we need to treat that actively with a topical corticosteroid. However, we do not continue corticosteroids all throughout, for example, for 30 days, 40 days. What we do is we give it for approximately around 5 days of that particular week. Then another 3 days or 4 days over the weekend, for example, we switch over to a non-steroidal applications like a topical calcineurin inhibitors. Then coming to the next point about antihistamines. Now, antihistamines are used, you have hydroxyzine, you have levocetrizine, which can be used from pediatric to geriatric age groups. But please remember that antihistamine is just a symptom relief. It reduces the itching. The main concept in atopic eczema, control flare-up is basically the topical applications or maybe the systemic immunosuppressives in the very severe cases. Antihistamine is not the first line therapy, because in many prescriptions that come in from many physicians, I have seen that they write different groups of antihistamines in that particular patient, but remember, it does have its own detrimental effects in particular patients. So as I've mentioned, topical steroids are very effective. Mometasone furoate, the moderately potent topical corticosteroid, is the one that can be used in a short period of time, around 4 days, 5 days, to control such form of eczemas, as you can see in the picture. Secondly, it should be used, remember, in a very limited time, not for a very long period of time. Creams can be used for the dry lichenified lesions, and ointments can be used for the weeping, oozing lesions in which sometimes the patients come in. And lotion and scalp lotions can be used for the hair bearing areas. Then there are steroid sparing agents like topical calcineurin inhibitors like tacrolimus ointment, pimecrolimus, which can be given continuously for a period of around 2 to 3 months in a very potential way. They do control the number of flare-ups and reduce the burden of corticosteroids in patients. Now, coming to the last 3-4 slides. What about oral cyclosporine? Now, oral cyclosporine is one drug that we have used. Many of our colleagues are using it all over the country for very severe atopic eczemas, like the earlier photograph that I had showed you. Now, in erythrodermic, that is when more than 90% of body surface area is affected, we need to give this form of an immunosuppressive, because it works and brings the inflammation under control the fastest within around 2 to 3 weeks time. But please remember, cyclosporine needs to be monitored in terms of the renal profile, in terms of the blood pressure, in particularly the adult group of patients, whereas in children also the same monitoring needs to be done once in a while, and we can give it for a short period to basically bring the disease under control. And narrowband UVB light or excimer light therapy is also commonly used for such cases of atopic eczema. As you can see in this particular child who I have been following up for the last 4 to 5 years has improved, and presently his into remission, and his quality of life has definitely improved. So when it comes to safety, it has been shown that pimecrolimus and tacrolimus are very safe. One very important practical point I would like to suggest is about tacrolimus as an ointment can be used twice a day. However, in certain patients, it has a potential to cause a little stinging, so it can be kept in the refrigerator in a box and then can be used. That reduces the stinging. Of course, there is this new update about role of probiotics in the treatment of atopic dermatitis, and there is a role of biologics like dupilumab, which is now FDA approved for the treatment of adolescent patients 12 years and more, and the newer concept of JAK inhibitors and apremilast, which are the newer line of medications. So coming to the last slide, that is the newer challenges. So we know that atopic dermatitis in adults and children is increasing in the prevalence. There is an improved in the adherence to treatments among patients. If you counsel them well, counseling is the key role. A lot of newer studies should be done, especially from Indian population, to show that basically we can definitely manage it, improve the management in patients. And I would thank you so much.
Thank you, Dr. Praveen Banodkar. There's one question: role of oral ceramides in AD, and can it be given to children, and what are the doses?
Yeah, so oral ceramides are basically more of health supplements. They reduce the number of flare-ups in the child, reduce the burden. There is no particular dose per se in ceramides, like being a health supplement. For example, now how we give probiotics. Similarly, these oral ceramides can be given in a syrup format. 5 ml per day can be given for a period of around 3 months. Then you can give a break, for another 2 to 3 months, and then restart the patient on that.
Okay.
Thank you very much, Dr. Banodkar. You had come, you had joined with a very short notice.
Yes, thank you.
And I've seen you in many webinars.
Right.
Today was a very excellent presentation.
Thank you, sir. Thank you for the kind invite. Yes.
Are there any questions?
One came, I think, one more.
So what about this? There are so many steroids are there. Which is the best? I mean, which you recommend?
Yeah, right. So as I mentioned during the talk, this mometasone furoate, that is the cream or the ointment formats are good. One very important point here is about when you are talking about a tube, there are creams, there are ointments. There is a very difference in terms of as a vehicle that can be used. So as I mentioned in lecture, the ointments can be used for the very oozing kind of lesions. You don't have to worry about infection. It is more of an exudate of the eczema. So the mometasone furoate ointment seems to work the best, in our group of patients. Of course, around the eyelid areas, corticosteroids need to be avoided. There you can use these top non-steroidal options like tacrolimus or pimecrolimus, which I've mentioned in the similar format twice a day for a period of 2 to 3 weeks. And the duration of steroids, I can see one question that has come up about how long can we use the steroids. Remember, the steroids should be used very judiciously for a short period of time, only to control the flare-up. It should not be used for maximum for a period of around 1 week to 2 weeks time, and then switch over the patient to the non-steroidal options that I had mentioned.
So in your second or third slide, you have said that vitamin D can aggravate atopic dermatitis.
Deficiency, vitamin D deficiencies.
So we can recommend vitamin D.
Yes, because vitamin D actually in our field of dermatology is showing a lot of promise in terms of controlling the inflammatory profiles. When you are talking about from atopic dermatitis to even psoriasis or lichen planus, what we are seeing that when we supplement the patients with vitamin D, the overall inflammation tends to reduce. So yes, and there are some studies which have shown that the deficiencies can aggravate this overall allergies. Role of Montelukast, I think I just see one maybe question,
Yeah,
if I can take it up. Yeah. So Montelukast is basically given more for patients who are having upper respiratory tract inflammations, like a patient with atopic eczema having, an acute rhinitis or acute, asthma kind of a picture. In those bronchitis, in those individuals, I would suggest Montelukast. There is no particular role in atopic dermatitis management.
Okay.
Thank you, sir.
Thank you, sir.
Thank you very much. Thank you.
Moving on to the next speaker, I will request Dr. Kashyap Dakshini, Assistant Secretary, IMA CGP, to kindly introduce Dr. Rohan Chaudhary.
Good morning, friends. Dr. Rohan Chaudhary is a consultant hepatobiliary and liver transplant surgeon at Apollo Hospitals, Navi Mumbai. Dr. Chaudhary completed his MBBS from Grand Medical College and Sir J.J. Hospital, Mumbai, and MS in General Surgery from BJMC Sassoon General Hospital, Pune, and fellowship in hepatobiliary and liver transplant surgery from Medanta the Medicity, Gurugram. He has international visiting fellowship in hepatobiliary and pancreatic surgery in Tokyo Women's Medical University, Japan. Dr. Chaudhary has been in the field since 2014 and is involved in more than 1,000 liver transplant surgeries and more than 300 complex hepatobiliary surgeries. As a consultant, he has performed more than 300 liver transplant surgeries, including living donor liver transplantation, deceased donor liver transplantation in both adult and pediatric age groups. His areas of expertise include liver transplantation, combined liver and kidney transplantation, complex hepatopancreaticobiliary procedures, and many advanced GI procedures. Dr. Chaudhary has various publications in peer-reviewed and indexed national and international journals, and various awards to his credit. Today, he will speak on the current status of liver transplantation in Western India. Welcome, Dr. Chaudhary.
Good morning, everyone. Am I audible?
Yes, sir,
Yes.
you're audible.
I am Dr. Rohan Chaudhary, consultant and clinical co-lead in liver transplantation, Apollo Hospitals, Navi Mumbai. I'll talk on current status of liver transplantation in Western India. I'll start my presentation with few cases. So this child at 8 months of age presented with vomiting of blood, was evaluated and diagnosed as Budd-Chiari syndrome. At that time, he was managed with TIPS procedure. At the age of 1.5 year, he represented with vomiting of blood, and the TIPS was blocked. He had poor weight gain and enlarged liver and ascites. He had coagulopathy, and his oxygenation was poor because of cirrhosis. He needed a liver transplant. His mother was willing to donate. She lost 12 kg weight to become fit as a donor. His father was a common man with a monthly income of 10,000 rupees. So he underwent liver transplantation in 2017 August, thanks to all the NGOs and trusts to support the transplant. This is another case at age of 10 months. This child was diagnosed with progressive familial intrahepatic cholestasis. At age of 6 years, his liver disease progressed rapidly, and he had decompensated chronic liver disease. He needed a liver transplantation. Aunt donated left lobe to him. His father was a common man with 25,000 monthly salary. And because of the crowdfunding supported by more than 1,300 supporters, we could do the transplantation. This is another difficult case where this 45-year-old male who was having liver cirrhosis because of hepatitis B infection So over 3 years, he became sarcopenic. He had abdominal distension. He had multi-organ failure, and later on, after stabilization, he was advised liver transplant. He underwent liver transplantation in March 2017. Wife was donor, and now both are doing well. So, just with introduction of these cases, we will talk about the milestones of in liver transplantation. So, in first liver transplant was done in US in 1963 by by Dr. Thomas Tazel. He is known as the father of liver transplantation. The first transplant in Europe was done by Royal Khan, and he that was the first transplant in whole of Europe, and it was successful transplant. And first transplantation in France was done by Henry Bismarck. So these are the stalwarts in cadaver liver transplantation. Then Dr. Tanaka in 1990 pioneered the living donor liver transplantation in Kyoto, Japan, and then thereafter liver transplantation numbers have been increasing. In 1970s, the survival was less than 50%. In 1980, in the cyclosporin era, it was 50 to 70%. It was in the tacrolimus era that survival went more than 80%. And after 2010, the survival is more than 95% because of most of the difficulties have been overcome. So now liver transplantation is the definitive management for end-stage liver disease in Europe, as it is shown in the ELTR data. After 1983, the number of liver transplantation for end-stage liver disease have been rising, and it's now become a definitive treatment. This shows the liver transplantation in the world. The United States and Korea and most of the European countries have the highest number of cadaver donor liver transplantations going on, whereas India is far from the Western world, and we need to improve in this. So in India, India is mostly dependent on living donor liver transplantation, whereas the Western world and the developed worlds are dependent on disease donor liver transplantation. So in this talk, I'll talk about which patients to transplant, about the operation, the complications, the DDLT and the LDLT, and liver transplantation seen in India and Maharashtra. So whom should we transplant? So indications of liver transplantations are chronic liver disease because of viral hepatitis B or C, alcoholic liver diseases, autoimmune hepatitis, and non-alcoholic fatty liver disease. The red ones are the causes in children: congenital liver fibrosis, biliary atresia, tyrosinemia, hyperoxaluria, Wilson's disease, and hepatoblastoma. So in India, the most common cause before was hepatitis. Now NFLD, that is non-alcoholic fatty liver disease, and alcoholic liver disease, the numbers are rising. So HCC, when performed within UCSF criteria, we can get good disease-free survival. The UCSF criteria is maximum tumor diameter of 8.5 centimeters single or multiple. Talking about fulminant hepatic failure, it is acute liver failure within 8 weeks of onset without any previous liver disease. They get high priority on waiting list. The KCH criteria needs a special mention when there is encephalopathy and acute liver failure with INR of more than 6.5, with more than 3 of these variables like age less than 10 or more than 40, non-A, non-B hepatitis, or when the duration of jaundice before encephalopathy is more than 7 days, and Billy more than 17 and INR 3.5. When these criteria are met, it warrants urgent liver transplantation. So, patient selection according to the ASLD guidelines, any liver cirrhosis who has decompensated with ascites, HE, any bleeding with a MEL score more than 15, is eligible for a liver transplantation. There are few male exceptions where male less than 15 can have an early liver transplantation when they have refractive ascites, recurrent bleed, recurrent encephalopathy, HPS, PPH, and intractable pruritus. Some cases of malignancies like HCC needs early liver transplantation, and there are few liver diseases which have mild exceptions. So, talking about disease donor liver transplantation, a brain dead person can donate his organs when family members give the consent. So, brain dead is defined as a irreversible loss of all functions of the brain, including the brainstem. The three essential findings in brain death are coma, absence of brainstem reflexes, and apnea. So, after declaration, if the family consents, then we can use the liver for and kidneys and other heart. Total 8 to 9 people can receive organs from a cadaver. So usually a disease donor liver transplantation, the incision is L-shaped in recipient. So this is the explant liver, cirrhotic liver. The difficulties that we encounter sometimes is intra-abdominal varices because of the portal hypertension. That is the reason that the liver transplantation surgery can be very bloody. Then we encounter difficult cases where there is portal vein thrombosis, previous steps. So the recipient hepectomy surgery is becomes difficult. So this is the case where we had to remove the whole inferior vena cava, and this is how the liver looks like in the bench. So there are a few cases in DDLT where we have to replace the whole cava along with the whole liver. In the piggyback technique, we preserve the recipient's native IVC and we do a double cava anastomosis. In the portal vein anastomosis, the difficulties that we find is when there is a previous portal vein thrombosis. That time we have to do a portal vein thrombectomy, or sometimes we have to take jump graft. And sometimes when we are unable to take inflow from portal vein, then we can use a collateral vessel or left renal vein for the inflow. Arterial anastomosis, most common anastomosis is the donor common hepatic artery to the common hepatic artery of the recipient. There we do see variations, but mostly they can be managed in benching and during the anastomosis. Biliary anastomosis is the Achilles heel in liver transplantation. Vascularity of the bile duct is looked upon. Duct to duct is the most common anastomosis. Duct to roux we perform in primary sclerosing cholangitis, retransplantation cases, and biliary atresia. So these are the complications that we see after liver transplantation. The non-surgical complications like acute rejection and infections are common, and surgical complications like bleeding, hepatic artery thrombosis, and biliary complications are less common. So where does this liver come from? These liver donors are either disease donor, donation after brain dead, or a living donor. In disease donor, we get a full size liver. In living donor, we get a partial size liver. So a living donor on evaluation, after doing blood test and ruling out fatty liver, we do a CT triphasic scan and we create a 3D model of the liver. And this is how the 3D model looks like. Here we are, this is the hepatic vein anatomy where we are able to divide the liver into right and left. This is the line of division. This is the portal vein anatomy where we can see the right and the left portal vein and plan where to divide. This is the arterial anatomy. We can see the right and the left hepatic artery and plan where to divide. So due to the imaging advancements, the pre-planning of living donor, we can uh, uh, we can tell how much liver is going to be donated and how much liver is going to remain in the donor. This is a case, alcoholic liver disease, who had a cirrhotic liver. It was removed. Whole liver was removed, and this is the donor liver. His son was the donor. This is normal looking liver. This is after clamping the inflow. This is the line of transaction. This is the left lobe. This is the right lobe. Then the liver is transacted. This is after transaction. It looks like this. And after removing the right lobe, this is the remnant, the remaining liver, which is around 40%. So in the right lobe is then perfused in backbench with University of Wisconsin solution, UW solution. And as the middle hepatic vein was was left in the donor, we had to reconstruct this in the backbench. And this is after implantation in the recipient. This is a very well perfused liver. This is a very well perfused liver. So that patient was donor was discharged in day 5 and recipient was discharged in day 15. 1 year post transplant, both are doing well. So what are the key principles in living donor liver transplantation? Donor safety is paramount. Minimum 35% donor liver should be left. So some institutes choose 30%, and we should aim for more than 0.8 GRWR, that is graft to recipient weight ratio. And left lobe should be the first choice because has less complication in donors. Recipient outcomes is important, but success is usually defined after 2 operations in living donor, whereas it is only 1 operation in cadaver donor. So what are the advantages of live donors? The waiting period is less. There is no waiting list mortality. It optimizes the timing of transplantation. The preservation time is less, so the cold ischemia time is less. Quality of liver is predetermined and it is much better, and it increases the global pool of transplantable organs. Now, challenges in pediatric liver transplantation is, you can see the small size of the baby, the small size of abdomen, less space, the small size of liver, small vessels. So anastomosing with the donor graft is usually difficult. So usually a reduced left lateral graft is put in such small kids where there are three major anastomosis of left hepatic vein, left portal vein, and left hepatic artery. So they pose a technical challenge because of the small size. This is a case of a 4-year-old with metabolic liver disease, cirrhotic liver. This is after transplantation of the left lobe. Now the baby, 4 years after transplantation, is doing well. At Apollo, 68% is adult liver transplantation, 32% is pediatric liver transplantation, 72% is living donor, and 28% is cadaver donor. We can proudly say that almost around 49% have received financial support, and it's to give the transplantation have been done in lower socioeconomic group. The 44% has been by charitable institutions, NGOs, trust. 5% has been supported by the hospital. This is a kid, Ram. He was diagnosed with biliary atresia. He underwent Kasai procedure this year, and which failed. He was not gaining weight. He underwent a liver transplantation. Now, post liver transplant, 4 months, he is doing well. This is another kid who is the youngest kid in our series, a 4-month-old from Tanzania who underwent a liver transplantation. Now, cost of liver transplantation, it is around $140,000 in United Kingdom, $250,000 in US. That accounts to 1.2 crore rupees in United Kingdom and 2 crore rupees in United States. In India and in Apollo hospitals, pediatric package is around 16 lakh and adult package is around 19 lakh. So the myth that liver transplantation is very expensive in India, it's wrong. It is less than a tenth cost in UK and US. So many of our patients still cannot afford. So there are a few examples. This 2-year-old who needed a transplant, with the help of more than 700 supporters, 14 lakh rupees was raised. For this 5-year-old who underwent a transplant in 2019, 16 lakh rupees was raised. And this truck driver's girl received a transplantation in 2021. For that, 9.7 lakh rupees was raised. And this kid, as I've already told in the beginning, first 4 cases, so he received 25 lakhs from crowdfunding. So such kind of financial support to the lower socioeconomic kids and adults have led to liver transplantation for the poor. Conclusions for liver transplantation is it is excellent treatment for end-stage liver disease. Technical issues have largely been overcome today, and there is good long-term survival. There is less chronic rejection, and the most important thing for in liver transplantation is teamwork. All members of the team should be skillful, and the juniors should learn from their seniors. At Apollo till now, 170 transplantations have been done. Almost around 70% is living donor, and in pediatric liver transplantation, it is one of the leading centers in Western India. And Apollo as a whole has been in the forefront in solid organ transplants, with more than 22,000 transplants performed all over India. And there are almost around 24 centers of Apollo with more than with around 300 clinical talents in transplantation all over India. This is the footprints in Western India, where we have done transplantation from many states, many districts in Maharashtra and Gujarat, and few international. So in our partner institutes, we have performed few transplants in. So these are our partner institutes. This is our team. Our team consists of more than 20 doctors, and every one puts in their essential inputs. So how does it transforms life? So it's very interesting to see this miracle, which we cannot imagine when we see the patient. So this is Sylvania, a 22-year female who had acute liver failure in 2019. Now she is doing well. This is a 2-year-old kid who was transplanted in 2020 for biliary atresia. Now is doing well. This is a kid, 5-year-old kid who was transplanted for metabolic liver disease in 2020, is now doing well. So this gentleman was suffering from hepatitis B, liver cirrhosis, and decompensation. He's a businessman from Nasik. He's doing well. This 15-year-old female was suffering from Wilson's disease. After transplantation, is doing well. So this kid was suffering from biliary atresia after transplantation, doing well. This young kid had citrullinemia. Now he's doing well. So the 6-year-old female kid, a female child, doing well after transplant. Uh, and this 13-year-old kid with Wilson disease now doing well. Sagar Gadkari, who had alcoholic liver disease, then he left alcohol, but his disease was progressing. He received a DDLT and now he's doing well. This 41-year-old gentleman was transplanted this year and he's doing well. So we thank to all these organizations for supporting transplants in Apollo hospitals. So these are the children who inspire us. They are the liver transplant kids who are our heroes now. So thank you so much.
Thank you, doctor. Any questions from panelists?
So what are the
Somebody's
chances of developing hypertension after liver transplant?
So portal hypertension usually reverses in 2 months' time after transplant. So initially, because of the decreased sinusoidal pressure, this pressure eventually takes time, and almost by around 2 months, it is resolved.
Hi, Dr. Kashyap here.
Yes.
I have a question, two questions. One is, what is the approximate average wait time in the country or state for a cadaveric liver transplant? And the second question is, what are the absolute contraindications for a living donor?
So for waiting time for sick patients in Maharashtra, now the waiting time, average waiting time is 2 months. And for stable patient, it is like more than 1 year. So this waiting period is increasing because of male priority being given in Maharashtra. Previously, it was based on when first come first basis that a person who has listed before getting the liver. So right now, at present, post-COVID, the priority is given to high MEL score. So high MEL score patient usually get a liver within 2 months, 2 3 months time, and most of the patients they don't make it till then. So sometimes we have to counsel them for living donor liver transplantation. And absolute contraindications. So for that, we will have to talk about the who are eligible to donate. Usually, it is a compatible blood group donor, 18 to 55-year-old, should be non-fatty, should be a relative, and fat more than 20% or remnant less than 30%, and BMI more than 33 are usually the contraindications. Relative contraindications are recipient based when the GRWR, when the liver is small for the recipient size.
okay. Thank you, sir.
There are two questions
Yeah,
in the question answer.
yeah. There. What are the donor and recipient matching criteria?
So donor recipient should be blood group compatible. If blood group compatible means ABO compatible. If it is ABO incompatible, then we can plan for ABO incompatible transplant, where we have to prime the patient with rituximab prior to transplant to decrease their antibody titers for the respective blood group. And if the blood groups are A, B, then we can plan a swap transplantation, which In the first talk, it was discussed paired exchange transplantation. And the other thing is the GRWR, that is the part that is donated should match should be enough for the recipient, so that ratio, graft weight to recipient ratio is around 0.8. So we can go to as low as 0.7, but less than that, then we usually look for another donor. And if there are no other donors, then we usually advise them a dual lobe liver transplantation or make them wait in the cadaver list.
One was the cost. You told it's 20 lakhs, no? Around.
Yes.
Yeah. 20.
Pediatric, it is 16.
Yeah. And what about chronic alcoholic patients who don't stop alcohol? Do you take them?
So, alcohol patients who are not abstinent, liver transplantation is contraindication because it is a futile procedure. So, before liver transplantation, minimum of 3 months of abstinence is required. Regular psychiatric visits are required. A social worker or usually visits the family and sees whether he has absolutely given up alcohol. And if there is any relapse in this 3 to 6 months time, then usually we don't offer liver transplantation to them. So liver transplantation abstinence is mandatory. In 6 to 7% of patients whom we have transplanted for alcoholic liver disease all over India, we are talking about all over India stats, we see relapse. Post transplant, after 1 year, we see 6 to 7% relapse. That is called as recidivism. So these patients usually receive psychiatric counseling. Few patients land up for liver transplant, but it is contraindicated.
And one person is asking the success rate, lifespan after.
Success rate, now it has been 95%, more than 95% surgical success rate. And 5-year survival is around 80%. So the success rate and the survival has been improved, is improving because of the technical difficulties have been overcome, and now the immunosuppression are better. In the tacrolimus era, there is less chronic rejection, there is less incidences of rejection, less side effects that have been encountered. So life after transplant is as good as like that of a normal person without any other, with the comorbidity that the patient is having.
Okay, sir.
Yeah.
Thank you.
Thank you, Dr. Chaudhary, sir.
Thank you for the amazing opportunity. Thanks to the IMA team.
Thank you. Moving on to the next speaker, I will request Dr. Sarita Devi, convener IMA CGP, to kindly introduce Dr. Abhida Shah.
Dr. Abhida Shah is a full-time consultant neurosurgeon at Apollo Hospitals, Navi Mumbai. She has more than 2 decades of experience in her field. Dr. Abhida completed MS and MCH in neurosurgery from Mumbai University. She got a gold medal in MCH exams. She also did a fellowship in endovascular surgery from Mayo Clinic, Rochester, USA. Her areas of interest include skull-based neurosurgery, vascular neurosurgery, craniovertebral junction surgery, neuro-oncology awake surgery, brain mapping, intraoperative monitoring. She has 150 publications in peer-reviewed and indexed national and international journals to her credit. She has contributed in 14 book chapters and has given 70 presentations in national and international meetings. Dr. Abhida got the Indian Society of Neuro-Oncology President's Award for the Best Clinician Researcher in 2019 and Best Paper in International Conference on Complications in Neurosurgery in 2021. She was awarded the Spring 2014 Woman in Neurosurgery Greg Wilkins-Barrick Chair Visiting International Surgeon Award 2014 and the Vesalius Award in 2016 at American Association of Neurological Surgeons. Today, she will speak on surgery for brain tumors. Welcome, Dr. Abhida Shah.
Thank you, Dr. Sarita Devi, and thank you to IMA for this opportunity to talk on the subject that is my passion, surgery for brain tumors. So I'm going to share my screen. Is it visible?
Yes.
Yes, ma'am.
Okay, so I am a neurosurgeon. I did my neurosurgery from KM Hospital. I'm still attached there as associate professor, and I'm also a full-time consultant at the Apollo Hospitals, Navi Mumbai. I wanted to do neurosurgery since the age of 14. And for me, it's been an incredible journey. And I will show you the rewards that this journey has brought. So this beautiful organ that you see here is the human brain. And it is beautifully lying on the cranial base, as you can see here, the anterior and the middle cranial base. There was a time when neurosurgery was considered morbid. The results were not good. And there were people who used to say that you enter the hospital with some deficit, but you come out of the hospital without your life. So all that has changed. And brain tumor surgery has come a long way from just being life-preserving to being function-preserving. And I'm going to show you how. So this is the cranial base, and you have the anterior and the middle and the posterior cranial fossa. You will see a lot of anatomical images in my presentation because I like neuroanatomy a lot. And neuroanatomy is the basis of neurosurgery. If you've mastered the anatomy, the neurosurgery is fantastic. So this is the image of the brain lying on the anterior, the middle, and the posterior cranial fossa with the arteries and the veins. This is the cerebellum. This is the temporal lobe. And this is the naked brain with all the pia and the vessels removed. And these are the lobes, as you know them as probably 4 lobes, but I like to divide the brain into 7 lobes. So frontal, parietal, occipital, temporal, the insular lobe, the central lobe, which consists of the motor and sensory strips. And on the middle aspect of the brain, you have the limbic lobe. And covering the brain is this dura. And a lot of our surgery depends on this barrier. Even corona that we've seen in the last 2 years has had difficulty transgressing this barrier. So this forms an important barrier and an important landmark for our surgery, as I will show you in a lot of images. So let's start with brain tumors. So as you all know, brain tumors can be benign and malignant. They can also be classified as being intraaxial and extraaxial. Intraaxial meaning those that are in the depth of the brain, on the cortical and subcortical regions of the brain. And more common of these are gliomas. You also have ependymomas and the like. And extraaxial tumors, the common ones are the meningiomas, schwannomas, epidermoid tumors. And I will just go through a quick procession of all these tumors. And I should tell you this, that no 2 meningiomas, like 2 fingerprints, have ever been alike. So even if you see 2 patients with 2 meningiomas in the same location, the surgery that will undergo for these tumors is different, because how they will behave intraoperatively is anybody's guess. So that's why brain surgery is quite beautiful, quite exciting, and the results are quite gratifying. So this is our experience with 129 cases of olfactory groove meningiomas. And mind you, this is the largest experience in the world. And these are the kind of tumors that we see that come to us. These patients actually present, why they become so big? Because this is a frontal lobe. So this is a silent area of the brain. So patients don't present till they have reached such big sizes. And when they reach such big sizes, they may present with cognitive problems. They will present with loss of smell, sometimes visual involvement. And this patient had actually come to us with a lot of disorientation. So I operated this patient, and you can see the tumor has been completely removed. She was in the ward, but 2 days after the surgery, she suddenly disappeared because she was quite disoriented from the beginning. But then later on, we found her on the footpath and we had to get her back. And now she's absolutely fine. It is now more than 5 years follow-up, and she's doing great. And this is the follow-up scan. This is again another tumor in the olfactory groove region, and you can see the preoperative and postoperative images. The patient is doing well. So these are the kind of meningiomas that you see in this upper image that we treat. And a lot of our experience, we have a lot of experience with these tumors. I have been trained by Professor Atul Goyal, as you must all be knowing, and I follow his surgical philosophies. So this is a patient with a suprasellar meningioma, a tuberculum cellae meningioma. They present with visual complaints. So if you see a patient with saying that they cannot see properly or they cannot see from the sides, that is because there is compression of the optic nerve and the optic chiasma, and an MRI is indicated. And you see how critical this location of this tumor is. This is the ICA, this is the middle cerebral artery, and this is the internal carotid artery, the anterior cerebral artery, as it goes on to continue into the A2 part. And this small thing that you see here is the anterior communicating artery. And you see how the tumor is related to it. So the surgery revolves around this, preserving these vessels, avoiding any damage. And you can see that we have been able to do this successfully. And this is the post-operative image showing the resection of the tumor. I will just show you a surgical videos because, you know, sometimes the anatomy of these tumors is beautiful to appreciate and see. So this is a small craniotomy that I've performed. This is the region of the frontal lobe. You can see me retracting here. And then the first step is that we release CSF from here so that the brain becomes lax. And then we go into the tumor. Now you see this is the tumor, and it's straddled by the optic nerves on both sides. So the criticality of this tumor is you have to preserve the vision of this patient. Not only preserve, you have to actually improve the vision of this patient and avoid injury to the vessels that we have done successfully. So you see this structure here is the optic nerve, and you see how the tumor is actually straddling the optic nerve. She had very low vision, probably close to blindness in this right eye, but after surgery, we were able to achieve some kind of vision in this patient, and she's doing well. And now you see the whole tumor is being excised. And this structure that you see here is the pituitary stalk. That is the other thing that has to be completely preserved while doing surgery on tuberculum cellae meningioma. And this is the opposite optic nerve. And this is the region of the suprasellar region of the tuberculum cellae and the dorsum cellae. Going forward, this is another patient. Again, you can see how it is related to the vessels and how vascular it is. There are flow voids inside the tumor. And this is the post-operative scan I have removed, and the patient is doing well. This is another very dangerous tumor for us. This is a petroclival meningioma. Not dangerous, otherwise it's a benign tumor, but dangerous because of its location. You see it is located in the posterior fossa, and it has all nerves straddled with it. Again, for the first time, this approach was described by Professor Goyal, and I'm using this approach to use these tumors. And you can see some pre-operative and post-operative images showing complete resection of the tumor. Again, another formidable tumor, and you see the post-operative image and the patient doing well. The problem with these tumors is they come with little ataxia. They might come with some cranial nerve deficits, but post-operatively, if you cause damage, you will give them a 5th cranial nerve, a 7th cranial nerve, or lower cranial nerves, and which will be very bad for their quality of life. So this is just some intraoperative images. This is the cerebellum being retracted. This is the tumor. And this is showing you excision of the tumor and all the cranial nerves. So see, you see this? This is the 5th cranial nerve. Here, this is the 7th cranial nerve. These are the lower cranial nerves. And you see all of them have been preserved. So this is again another formidable tumor going into the cavernous sinus. And you can see the post-operative scan showing resection of the tumor. Another tumor going in the cavernous sinus. So it's a spinopetrocavernous meningioma. And you see the post-operative scan with resection of the tumor. Then next, coming to the posterior fossa, more in the backside, you have the foramen magnum, and foramen magnum meningiomas are again beautiful tumors. Problem with these patients is they come with spastic quadriparesis. One side may be weak, or one arm and the contralateral leg may be weak. And this is the picture that you see on the MRI. You can see how the cord is compressed and completely draped over the tumor, but they can be beautifully operated. The key point in this tumor is preserving the vertebral arteries. You see these 2 black dots here, that is the tumor with the vertebral arteries on both the sides. So obviously I went in from the back and removed the tumor, and the patient did well. So this is another patient here. You see the vertebral artery straddled by the tumor, and post-operative image showing excision of the tumor. Patient improved in the quadriparesis and is now walking. This is another challenging thing that we came across, ossified anterior foramen magnum meningiomas. So you see in this CT scan here, they're absolutely like rock, but we have still operated these patients. They're soft rocks. So if you know how to break the tumor, you can go ahead and operate on these tumors. And this is the post-operative scan. And this is the experience that we published. And again, no one in the world has done these kind of tumors. You see here, this is calcified. This is a CT scan, and you see the calcification in the meningioma. And this is the scan. This patient was refused from many hospitals, and then they ultimately came to us, and then we removed this tumor, and the patient doing well. Coming back to the middle fossa and the cavernous sinus. So the cavernous sinus was supposed to be a no man's land, difficult to enter because of these venous spaces, because of this internal carotid artery. But of course, as neurosurgery has gone, we have captured the cavernous sinus, and now we are able to enter into this and operate on these patients. So you see now I have removed the veins. This is a cadaveric image. So this is the this is the third cranial nerve. This is the V1 part of the fifth cranial nerve. This is the V2. This is the V3. This is the Gasserian ganglion. There you see this structure here that is curving inside the cavernous sinus is the internal carotid artery. This is the optic nerve. This is the fourth nerve as it is entering the orbit. And this is the beautiful image of the cavernous sinus. Now you see these drawings, these colored things that I've done here is the entry points where we can enter into the cavernous sinus and actually excise tumors of this region. So you see this tumor, this is the region of the cavernous sinus. This is a cavernous sinus meningioma arising from the wall of the cavernous sinus. Again, I have removed this tumor, and you can see the post-operative image showing the complete resection. These are difficult meningiomas. These are involving a part of the cavernous sinus, but they're also involving the anterior clinoid process. So they go in one side and on the other side of the anterior clinoid process. Little formidable tumors to operate, but if you're able to do a good surgery, you can see the post-operative images showing the resection of the tumor. Is again another anterior clinoid meningioma showing the resection. Again, another classical anterior clinoid meningioma. This is the post-operative scan showing the tumor resection. This is again a tumor that I had operated 4-5 years back. This patient again came with weakness on one side, and you can see how the internal carotid artery is straddled inside the tumor. And you can see that I operated by two approaches. First, I went from the middle fossa, removed this part of the tumor. Then I went from the posterior fossa and removed this part of the tumor. You can see here the basilar artery is also encased by the tumor. And this is the post-operative image showing the tumor resection. The next tumor that I would like to show you is a chordoma. Now, this chordoma is completely here in the cavernous sinus. So you see it is occupying the cavernous sinus. And this is the post-operative image showing resection of the tumor. And this is just a small video just to show you how the cavernous sinus looks after the surgery. So you see here, this is the V1, V2, this is the V1, and I'm entering in between. And this structure that you see here is the internal carotid artery in the cavernous sinus. And this is the image after tumor resection. So this is how we have also conquered the cavernous sinus. There are many approaches that we have devised for these clival tumors. And this is another supracerebellar approach where we go from the back actually and remove these tumors. And you can see the post-operative image showing the resection. This is again another beautiful tumor. Beautiful, why? Because it is the most benign tumor of the brain. If you remove this tumor, you're able to cure this patient. And this is again the largest experience in the world of surgery on these tumors, cavernous hemangioma of cavernous sinus. And you see how they present. So the patient actually presented to us with a third nerve and a sixth nerve. So these are the pre-operative images, and we operated on this patient. You can see the post-operative scan. I don't have time to show the video, but you can see after 3 months of surgery, all her deficits are better, and you can see the smile on her face, and all her eye movements are returned to normal. So this is the magic that now neurosurgery is able to afford to these kind of patients, that not only do we not cause deficits, but we improve the deficits that are caused. So these are our experiences on giant pituitary tumors. This is a paper that I wrote on the contributions of the department on understanding of the surgery of these tumors. So we've classified them into 4 groups and have advised surgery for this based on anatomical understandings. This is the pre-operative and post-operative images that you can see here. And this is another beautiful tumor that is a Cushing's disease. Again, important to realize that if the pituitary is a source of the Cushing's disease, of the Cushing syndrome, then we can definitely cure it. You can see this is the nodule, the microadenoma that you will see in a patient with a Cushing's disease. And this is post-operative. And you can see how the patient has improved in his facial features and in his Cushing's disease, and he's cured of the disease. Coming to the next kind of tumor. So schwannomas. Now, this is a tumor that we encounter every day in our day-to-day practice. This is an acoustic neurinoma. Patient presents with loss of hearing on one side, imbalance on walking, and giddiness. Very common complaints, subtle complaints. The patient can carry on with this tumor for a long time, but these tumors are beautiful to operate. And the aim of surgery should be only one, to preserve the face of this patient and to try and improve the hearing. So here you can see this patient completely on the day after, on the same day of surgery, no facial tumor, no facial deficit. This is again another large acoustic that I've operated, and you can see no facial deficit. This is a tumor that I recently operated about 20 days back, and you can see the immediate post-operative scan. He's just come out of the OT, and you can see the nasolabial fold is maintained, eye closure is good, and there is no facial paresis. So that should be the aim of surgery for acoustic. This is again another tumor that you commonly see. Next in line to acoustic for intracranial schwannomas is the trigeminal schwannomas. Again, we have a special surgical strategy to deal with this. We come from lateral here and remove the entire tumor. And this is the post-operative image showing the resection. This is again another tumor showing the resection, and you can see the post-operative image. This is again our experience on tumors with extracranial extension, where they go into the orbit, they come down into the pterygopalatine fossa, they come down into the infratemporal fossa, and we have done these tumors beautifully. We've described a reverse skull-base approach for going and approaching these tumors. Then this is a recent experience where we found that massive trigeminal neuranomas, sometimes they recur, and the ones that recur actually have had an apoplexy and they recur. This is again another oculomotor schwannoma, and you can see the post-operative image. It grows here in the roof of the cavernous sinus. Again, another difficult location to treat, but if you understand the dural anatomy, as I was saying, the dura is important. If you understand the dural anatomy of these tumors, you can perform a beautiful resection and preserve the eye movements of the patient. Again, another oculomotor typical schwannoma showing the tumor in the roof of the cavernous sinus. Again, another oculomotor tumor showing post-operative resection. These are experience. We have dealt with all schwannomas of the brain. So this is a facial schwannoma. This is how you preoperatively recognize it, going both in the middle and the posterior fossa, the bony erosion that it causes, and the post-operative, we can treat this patient. Lower cranial nerve tumoromas, again, the philosophy is important. You have to preserve lower cranial nerve function, because if you cause deficit on this, patient will not be able to swallow, patient will not be able to eat. That means you're hampering the quality of life of the patient. So your aim of surgery is to preserve lower cranial nerve function. And we have described a combined approach for these tumors. Here you can see the preoperative image, typically going into the region of the jugular bulb and the internal, following the course of the jugular bulb. And this is the post-operative scan showing the excision. Another huge tumor, lower cranial nerves, showing the post-operative image with tumor excision. These are some intraoperative images where you see that we have described the dural anatomy of these tumors and have protected the function of these tumors. So coming next to epidermoid tumors rapidly. Now these tumors, apart from benign, are the most beautiful tumors of the brain. They look like pearls. I will just show you some surgical images and you'll be very happy to see these tumors, and it is very gratifying to operate on these tumors. This is our experience again on anterior tentorial based epidermoid tumors. So I will just show a small video that I had operated recently, just to show you how the tumor looks. So this was the preoperative image. So you see this large epidermoid tumor. This patient actually came only with one symptom, giddiness. That's it. Because these tumors grow in symbiosis with the brain. Slowly, slowly, slowly they creep and occupy the spaces in the cisterns of the brain and cause very subtle deficits. So this is the patient, this is the tumor, and I'm operating. You see how this tumor is. It's white, it's suckable, and it is quite a beautiful tumor to operate on. And the post-operative aim of this surgery is to preserve. You cannot damage a single nerve, you cannot damage a single vessel. And I will just go to the end of this video to show you. You can see this, I'm removing the tumor now. This is in the region of the basilar artery. You can now, I've remove this bit, and you can see the basilar artery with all its perforators. And you see, I call it beautiful because the anatomy comes out so beautifully. And here you see this tumor in front of the basilar artery, behind the basilar artery, and going and encasing all the perforators, and that I'm removing now. You can see now this is the part of the tumor in the lower cranial nerves. You see, I'm actually trying to save this perforator, and that's why I'm going around the tumor, and I actually managed to save this perforator. And this is at coming to the end of resection. You can see the basilar artery very beautifully here once this tumor bit comes out. And this is the basilar artery with all its perforators. I don't think we have time to see the whole video. Here you can see the basilar with all its perforators, and this is at the end of resection where a complete resection of the tumor I had performed. So going further, these are pineal epidermoid tumors. Again, we have a very good large experience. I'm not going to show you the video, or maybe just a little bit, just to show the anatomy at the end. So this is supracerebellar, and you can see that I'm removing the tumor in this region. And the end of the resection shows that you are on top of the brainstem in the region of the posterior third ventricle. And you can see how I'm removing the epidermoid, saving all the nerves and the vessels. And you can see the tumor resection. And this is the beautiful anatomy. So this is the posterior third ventricle. This is the region that once I open this, I will enter the third ventricle and I will see the thalamus and, enter, and the foramen of Monroe and the massa intermedia and all these things. And this is a real picturesque site. So here you see the anatomy at the end of resection. This is again suprasellar epidermoids, again beautiful anatomy. So you can see how small our craniotomy is, how small and beautiful this is. And we are able to do these kind of tumors with basic understanding of how these tumors grow. And that's why we are able to get these results. I'm not going to go into this. Now coming to, we've done a lot of extraaxial tumors. Now rapidly, I will show you intraaxial tumors. And this is my recent work on the subject of gliomas. So I recently published this classification. As I told you, I'm interested in brain anatomy. I've studied the white subcortical fiber anatomy of the brain. And this is my recent classification on this subject. And based on this classification, this is a new understanding of the spread of gliomas along the fiber tracts. And based on this, this is our surgical strategy for removing these tumors. So this beautiful image is the image of the subcortical brain, where all the gray matter has been removed. And if you haven't seen, this region here is the arcuate fasciculus. This is the superior longitudinal fasciculus. This is the inferior longitudinal fasciculus. This is the middle longitudinal fasciculus. And it's just beautiful. I cannot explain to you. And based on this, I have divided gliomas into localized type and diffuse type. And we are using this surgical strategy for treating these tumors. So you see this tumor, see this image. This is the central sulcus. This is the motor area. And the tumor, low-grade glioma, is in this region. And it is in the region of actually the supplementary motor area. So even if the motor remains, sometimes the patient develops a deficit after surgery, but it recovers because it is supplementary motor area. And this is just a short clip. I will show you. This is the intraaxial brain. This is some monitoring that we have performed. Of course, we do both intraoperative monitoring and awake when needed. But in most cases, we are able to do it because of the understanding of these brain tumors that we have. So this is the en masse resection of the glioma that you can see here, that I'm removing. And this is the whole tumor that will be removed. And the patient is getting a good quality of life and a good radical resection of the tumor. So that will increase his survival. This is at the end of the surgery, showing the tumor resection. And this is the patient. This is the MEPs after the resection. This is the tumor. And you can see the MRI showing the complete resection. This is a tumor in the speech area. Now, this is also what, based on our understanding, we are able to use. So we have a lot of gadgets. We have neuronavigation, we have tractography, and all these gadgetry can be used to get into this tumor and remove it without causing a deficit. Of course, the anatomical understanding is the key. And again, I'm not showing you the video, but I will show you the patient the day 2 after surgery.
नाम बताइए पूरा. With Shriram Hiri.
So this is a tumor in the Broca's area, and I've removed the tumor completely, and the patient is speaking on day 1. So this is the kind of surgery that we are able to do. Again, high-grade tumors also. This is another tumor that I've removed recently in the region of the insula. You can see the post-operative resection. Again, another insula glioma showing the post-operative resection. High-grade tumors, understanding the displacement of the fibers. And this is a beautiful approach that is described. And we have done this approach, and this is the post-operative resection. Again, another no man's area. So cavernous sinus and brainstem. These are no man's, there used to be no man's area in the in neurosurgery. But now again, I have studied anatomy of brainstem, and based on the fiber organization, here you see how beautiful these white fibers look along with the gray matter. So we have done these kind of dissections and published our work. And I devised this approach to intraaxial midbrain tumors, and with beautiful results. So we go supracerebellar. This is the superior and inferior colliculi. This is cerebral peduncle. And this is the approach that I've described that is safe for the patient. And you can see that the tumor, I've removed this tumor in the region of the midbrain. And this is the patient with no deficits. I'm not showing you the video, another midbrain tumor. For deep-seated tumors, caudate head tumors, again, based on anatomical understanding, we have devised an approach. And you see this resection post-operative that the tumor has been removed. Again, we come back more to intraaxial, the large intraventricular tumors. We have a huge experience on this. And you see how our patients come typically with large tumors. That is the problem. And we have to know how to deal with it. And this is the preoperative and postoperative scan. Sometimes you can observe these patients. So this patient actually, 22 years he went without a problem. Only when he had a problem, we operated, and this is the post-operative resection. Intraventricular meningiomas, again, huge tumors, benign. If you know how to operate, you will cure the patient. So these are some pre-operative and post-operative images of the patient showing the tumor resection. You see this huge intraventricular meningioma. This is the approach that we have used, and the patient did very well. Sometimes we see recurrences. These are very unusual cases that we have seen, and it occurs actually along the tract of the surgery. So there are interesting observations that we have made during our era of brain tumor surgery. And it is very interesting, and we've gone back again and removed this tumor. It is easily possible. Now, just to end my thing, I will show you a couple of interesting cases, because this, it just came to us. So this young child, okay, I think he was about 15 or 16, came to us on day 1 with headache and vomiting. We saw this tumor here, lesion here. Okay, we decided to operate, but we thought, let's have an MRI of the brain. He went into the MRI suite, and you see where the tumor disappeared. From the frontal horn, it came to the third ventricle, and suddenly the patient developed eye problems. He had upward and sideward gaze restriction, and the tumor had migrated to this. So immediately in the MRI, we repeated again. And afterwards, again, after some time, we saw the tumor migrated to the fourth ventricle, all in one day. So from the frontal horn to the third ventricle to the fourth ventricle. And finally, I operated on this patient from the back and removed this tumor from the fourth ventricle, and he's doing very well. This was done about 2-3 years back. And this is still how our patients come. Can you believe this guy? I've done this in 2-3 months back. You see what he's roaming around with, as if he has a second head on the back of his head. I don't know why he was roaming around with this tumor for such a long time, but they become formidable for us because this is a meningioma, and then the blood loss is a problem. But still, I've operated this patient. This is my intraoperative image, and this is the post-operative specimen. You see, it was 18 centimeter and it weighed about 1.5 kg, probably one of the heaviest brain tumors in the world. And this is the post-operative scan showing complete resection, and the patient is doing well. So ours is a complex country because it gives us a lot of complex tumors, because our patients, sometimes wait before they come to us. It is not good for them, but it increases our experience on brain tumors. And this is how I would like to end my presentation. Thank you very much.
Thank you, Dr. Abida Shah, for the wonderful presentation. Any questions from the panelists? Sarita? Okay, thank you.
Thank you.
There is one question.
There is?
Question answer.
Achha.
What happens space after removal of tumors?
That space is occupied by CSF. So we like to say that brain tumor surgery is like a spatial surgery. You go in, you remove the tumor, make space, because you never know when the patient is going to recur, at least in malignant tumors. And then when it recurs, you can again go back in and make some space by removing the tumor.
What is the rate of recurrence?
It depends. So no tumors for gliomas, of course, for high-grade gliomas, there are recurrences, but with a radical resection, we are able to give at least 2 to 2.5 years of life with radiation. For low-grade gliomas with a radical resection, we now see 10 to 12 years of good quality of life. And for benign tumors, you can cure the patient. You will remove the tumor and they will go on to live a normal life.
What is the success rate, madam? After
Success rate is very, very good. Very, very good. Morbidity, mortality is very low, in the range of 1 to 2%.
There's one more question.
Yeah.
Glioblastoma multiforme, is it operable?
It depends on the location of the tumor. If it is extremely in the depth of the brain and it is high grade, we still try to decompress it, but otherwise all locations of the brain, glioblastoma multiforme is operable. And probably you should try to operate it, because you are able to, if the patient, you can give radiation and chemotherapy, you can give them about 2.5 years of life at least.
Thank you. Thank you, Dr. Abida Shah.
Thank you.
Thank you very much. Moving on to the
pictures.
Yeah.
Beautiful slides. She showed us. Yeah, very beautiful.
Thank you. Thank you, Dr. Sarita.
It was a visual treat. Okay. Thank you. Moving on to the next speaker for today's session, Dr. Hakimuddin Pardawala. Dr. Hakimuddin Pardawala is the head of internal medicine department at Saifi Hospital. He is also attached to Prince Ali Khan and Sabu Siddiq hospitals. He obtained his MD from the University of Bhopal and has strong interest in infectious disease, metabolic diseases, including diabetes, obesity, and respiratory ailments like asthma. He was one of the physicians who treated the cases of toxic gas exposure in Bhopal. Dr. Pardawala dedicates a significant portion of his time to conduct various educational seminars for general public and is known for his uncompromising dedication towards his patients. He has written chapters on malaria, cholera, leptospirosis, and listeriosis in gastroenterology and hepatology manual published by McGraw-Hill. Today, he'll be speaking on interpretation of fever profile. Welcome, Dr. Pardawala.
Thank you, ma'am. Thank you. Thanks to IMA team for inviting me for this CME. After listening to these young doctors who are doing very well, just a minute, I'm sharing my screen. Can you see the slides?
Yes.
Yes, sir. Yes, sir.
Okay, okay. So after listening to all these young guys with doing very well on whether it's a kidneys, brain or liver, now we move on to the most basic disease, that is fever, which is bread and butter for a general physician and a physician. Though we are practicing for so many years, but believe me, every time I come to know some interesting facts about the investigations we usually ask for. So what I am going to share is more of my experiences with these investigations and how to be careful about these investigations and how to interpret in a given patient. So we know that fever is the most common reason for a visit to a GP and a physician. And it can be most simple to treat fever patient, and it may be most challenging, as there are thousands of causes of fever and there are hundreds of tests available. So I always say that you need 100% of your brain while dealing with fever patient rather than stroke or MI, because there everything is fixed and you don't have to do too many investigations and apply your brain. Because fever could be because of infectious causes, which is the most common cause, like viral fever, malaria, dengue, lepto, UTI, URT, LRT, and cellulitis. Rarely it can be because of various malignancies, connective tissue disorders, and various inflammatory bowel disease, sarcoidosis, and so on. So it is the fever where actually the art meets the science. What I mean that is you have to really build a rapport with the family. You have to take a very careful history. You have to do a proper examination, gain the confidence of the patient, especially when the fever is not subsiding. And you have to explain the patient for the wait for the response of treatment. You should have a good knowledge about the disease, about epidemiology, about various investigations and treatment options. As far as acute febrile illness is concerned, the diagnosis of fever depends on 4 pillars. And the most important first pillar is a good history taking. There is no replacement of a good history taking, and a very proper good physical examination. And your knowledge of local epidemiology is very, very important. You should know that when the liver abscess comes, when the typhoid comes, when the dengue comes, and when the pneumonia comes. And then you should decide the relevant investigations, as you cannot go for all the investigations in every patient. So you have to choose your investigations according to the history, according to examination which you had, and according to epidemiology. My message always is to always think of common causes first, and there is no replacement of a good history taking and a proper examination. And investigations should be carried out judiciously in a proper background. Now, as far as history is concerned, I divide history in 2 parts. One is about the fever, the pattern of fever, high grade, low grade, with chills, without chills, and so on, intermittent or daily. But associated symptoms are equally important. That gives you a clue about the most likely cause of fever, like if patient has burning in urine, he has got a cough and cold, throat pain, pain in abdomen, you will get a good clue about the cause of fever. Travel history is important, sexual behavior is important, and professional history is very important. What he's doing is sometimes, let's say, for example, somebody is working in the sewage system or working as a butcher, then chances of leptospirosis will be very high. As far as examination is concerned, I really feel sorry that most of those nowadays we do not do a proper examination and we trust more on investigations, which is not fair.
So sorry to interrupt. The slides weren't moving. Just wanted to point out.
Oh my God. Same problem is coming. I don't know why it is happening. They're not moving now. So anybody can guide me how to go ahead?
Sir, go for slideshow, no?
Slideshow. This bar is not going. Slideshow, yeah. And then slideshow, and then?
You can say start from the beginning. You can just
Okay. Now you got it?
click it, sir.
Again, click karu?
Yeah.
Just do it. Now?
Yeah.
Got it?
और press करते जाइए.
Now see, is it moving? But now it is not moving. Yeah. Did it?
No, it is first, not moving.
Now? Still not moving?
No.
Oh my God.
The pen?
Shit. It's still not moving?
No, it's not moving.
Oh, what has happened?
Yeah. You came to 6th.
Now it's okay?
No, yeah, but
Diagnosis
go back, no?
of.
Acha, you want diagnosis of fever.
Now you got. Is it moving now?
Go to next.
Now?
No.
One slide, always think of common causes. No? History
No.
taking?
No.
Is it stuck to which slide?
Diagnosis of fever. The 6th slide.
So there is a bar down, notes, comments. Can you see? Last. At the end. One second. I'll just call up.
Sir, try to stop share, then again reshare and open your presentation.
Yeah, Dr. Pardawala will rejoin. He is left.
The pen.
Dr. Awad, Pardawala left, no?
Like, can you see me now?
Acha, he came. Acha. You are on the 9th slide.
Clinical examination?
Yes.
Okay. Now, investigations?
No.
Sir, can you just stop screen sharing and share again?
I tried, yeah.
Sir, do stop sharing and again restart. Yes.
Okay. Now again?
Now again share.
Okay.
Just click on the left hand side of any of the slide.
Now it's okay. Can you see investigations? Is it moving now?
No, sir.
No, no.
Click on the left side.
Yeah, I'm clicking on left side. I know what's wrong in that. So fine, we will go ahead.
So,
But then you have
so
to
can
say
you just close the PPT and just open the PPT again?
Okay. Just a minute. Can you see?
So you have to share the, you're not shared.
we can see you.
I know. These technical issues here, there is a big problem. Still you can't see?
First slide.
Presentation.
First slide is there. Is it going to
Yes.
second now?
So you can click on the presentation next to you. You can see
You
the
keep on
second.
clicking.
I think I will continue to talk and you can, because I'm not able to do this. So we were there at history taking, and clinical examination is very, very important. You can move it fast. Look for the neck stiffness, you look for the pallor, tonsils, look for neck glands and bronchial breathing, murmur, pulse, BP, liver tenderness, tenderness over bladder and rashes. Now, as far as investigations are concerned in acute febrile illness, I think minimum investigation should be done even in most poor patients because this is ethical and legal. Even if patient is very poor, get at least CBCSR done. So that will give you a lot of information. But if patient is having fever for more than 5 days in spite of your empirical treatment, then it will be criminal to treat that patient without investigation. So if patient cannot afford, better you send him to a government hospital. Now, as far as investigations are concerned, I divide fever investigations into 3 stages. Stage 1 means which should be done in every patient, like CBCSR, urine routine, culture SOS, MP RMET G6PD, Vidal blood culture, dengue profile like NS1 IgG IgM, and lepto IgG IgM. I think in Bombay, this stage 1 should be done in all acute febrile illness patients. Stage 2 includes LFT, random blood sugar, creatinine, ANA, HIV, X-ray chest, USG abdomen, 2D echo SOS. This should be done when you do not get a clue from first stage investigations. And when fever has crossed more than 10 days, and still if you are stuck not getting the diagnosis, then you should go for stage 3. That includes first test is CT chest, abdo and pelvis, or full body PET scan. You have to do sometimes CSF, bone marrow, and liver biopsy and BAL sometimes. Now, a usual fever profile includes CBCSR, urine routine, MP RMET, G6PD, Vidal typhoid dot test, dengue NS1, IgM, IgG, and blood culture. Can you see the slides or still you can't see?
Can't see. It is stuck on first slide.
So I will. Can I take the help of my son? Probably he might solve. I'll
Okay.
take the help because these slides are made very with great effort. So I would like you to see. Just a minute, huh? Hussein? Hussein?
Please wait for a few minutes.
Hussein? news. I'm sorry, he's also left. So we'll continue like that. So we will take first CBC. Why CBC?
Sir, you can click on the slides next to you. I mean, you can just try to clicking on the number 2 slide, 3 slide, that way.
Whichever you want.
I don't know why it's not coming. Yeah.
Sir, in the right hand side, there is a slide. Yes, correct.
Now you can?
Yes.
Now you are able to see?
Yes.
Yes.
Perfect. So why CBC is so important? This slide, I have made personally. And if you remember this slide, you can diagnose most of the acute febrile illness with just 2 or 3 investigations. So you just do a CBC and look for 2 things. What is the WBC count and what is the platelet count? And divide the patients into 2 categories. Those who got a high WBC count, then in India, the possibilities are UTI, URTI, liver abscess, leptospirosis, skin and soft tissue. So it becomes very easy. Skin and soft tissue will not be hidden. So you will come to know there is a cellulitis or historectal abscess or something. About UTI, definitely there has to be symptoms. URTI, LRTI, there will be cough, cold. And if you have a punch sign positive, then most likely it is liver abscess. Leptospirosis, you can confirm with other investigations. So this whole separates this group. Now, if you get a patient who has got a normal or low white cell count, divide them in 2 categories. Those who have got a low platelet count, then possibilities are just 4. Either it is malaria, viral fever, dengue or chikungunya. In that case, if it is malaria, look for a spleen. If it is viral fever, there will be cough, cold and coryza. And if it is dengue, the fever will be continuous. If it is chikungunya, there will be a lot of joint pains. And you will end up with very 1 or 2 tests and you get the diagnosis. If the platelets are normal and WBC is also normal, then there are 2 possibilities. Tuberculosis, if there is a weight loss or a prolonged history. And if it is a short history, say 5, 7, 10 days, then most likely you are dealing with enteric fever. So straight away you will go for blood culture and Vidal. So that's why the importance of CBC, I call it the mother of all investigations. So in all acute PUOs or acute febrile illness, the interpretation of CBC is the most important thing on which you decide that what other investigation you will go for. And if suppose you have in first CBC, you are not able to diagnose, then if the patient is continuing fever, then every 2nd day or 3rd day, you should repeat CBC. Why it is important to repeat CBC? Because the rising hemoglobin level and dropping platelet count will usually indicate a dengue fever. What happens is in dengue, there is a hemo concentration taking place. So hemoglobin will keep on rising. Say today it is 10, it will become 11, it will become 12, 13, 14. While if hemoglobin is dropping and platelet levels are also dropping, in that case, it will suggest you of malaria, because in malaria, with every passing day, the hemoglobin will drop and platelets will drop. And if you find rising WBC count, then most likely you are dealing with bacterial infection. So there is a lot of importance of repeating CBC very often. Now, few words about ESR. We usually give a lot of weightage to ESR, but in acute febrile illness, really ESR is of no value. Commonest cause of high ESR is anemia. And remember, for every 1 gram of less hemoglobin, there will be rise of 10 ESR. So normal ESR, say for example, is 20. Then if some lady has got a hemoglobin of 10, then she is deficit by 3 grams. So 30 plus 20. So that 50 ESR will be normal for her. But if you get a very high ESR, say more than 100, then definitely you should think of tuberculosis or HIV. Otherwise, there is no much role of ESR in acute febrile illness. Now we go to urine test. The importance of urine routine. Can you see the sliding slides? Are you able to see the? Yes. In a case of fever, what information you get from urine routine? Number 1, the most important is UTI you can diagnose on the basis of urine routine report. If pus cells are increased, if bacteria is plus, or if hematuria, then there is a strong suspicion of UTI. You can diagnose jaundice, bile salt, bile pigment will be positive. In an undiagnosed case of diabetes, if urine sugar is 2 plus, 3 plus, you may think of that patient has got diabetes. You may diagnose hemolysis in presence of malaria. You will get hemoglobinuria. You may get a ketone positive, which will become an indication of hospitalization. It may be because of diabetes, or it may be because of poor carbohydrate intake leading to ketosis. So this is the importance of urine routine. Now, normal number of pus cells in urine in male are up to 5 and female up to 10. But remember, mere presence of pus cells does not always indicate UTI. We have hundreds of diabetic patients, especially female patients or elderly male, whose pus cells may be 60 to 80. So remember, that is not the cause. If patient is asymptomatic, does not have any symptom related to urine, then this pus cells is an asymptomatic pyuria. But if a patient who has got symptoms like dysuria, increased frequency, burning in micturition, then even if pus cells are not present, it is UTI. So it is the symptom which is the most important thing. When you suspect of UTI, then other than pus cell, you look for leukocyte stress positive, then pyuria. Nitrite positive strips are available by which you can confirm the UTI. Now, once you confirmed, a few words about these new tests which are available. Various dipsticks are available, which all family physicians should now keep at their clinics, and they can help you a lot about the diagnosis of various conditions. If you see here, if there is a multi-strip is available, where all these parameters you can get on the spot, and you can diagnose UTI and various other conditions, and they are very helpful. So these are various strips which are available, and you can use them. About urine culture, if normal standard is more than 10:5 colonies has to be positive. But if you follow this rule, 50% UTI you will miss. So now 10:3 to 10:4 is accepted as a significant bacteremia or pyuria. And with urine culture, you can know the organism and you can treat the diagnosis, patient's condition. Now, few words of asymptomatic bacteriuria. There are good number of patients where urine cultures are repeatedly positive, but patient doesn't have any symptoms. So ideally, they should not be treated until and unless patient has got a pregnancy. There you have to do an investigation, find out and treat the even asymptomatic bacteriuria. Now we move on to the malaria, role of MP, RMET and G6PD. Few words about malaria diagnosis. We know that malaria is preventable, curable, and millions of people that die each year because of malaria. In malaria, remember one thing, that early diagnosis and a prompt treatment is the most important thing. This will prevent various complications and it will help in preventing the spread of the disease. Now, as far as diagnosis of malaria is concerned, remember that peripheral smear is the gold standard. You should take at least 2 to 3 peripheral smears, and it should be taken immediately after a spike or between paroxysms. And whenever required, it should be repeated, and always make a thick and thin film, very essential. And with thick film, you get a diagnosis, you see the parasite. With thin film, you confirm the species. And the importance of peripheral smear is you can have a parasite count, so you can have an index, you can have RBC morphology, you can judge about parasites also. But the problem is that most of our labs where we send the investigations, they are run by poorly trained lab technicians, and hardly there is any pathologist available. So the peripheral smear reports becomes unreliable. And in India, we have seen that peripheral blood smear pickup rate is just 20 to 25%. And another very interesting thing is most of the labs and hospitals in our city, they are using venous blood to prepare the peripheral smear, which is not the right way. Ideally, it is the capillary blood should be taken from fingertips to prepare the peripheral smear, because this has the peripheral blood has got a highest concentration. In this latest report, which was published in 2018, it was found that venous blood is much inferior than the capillary blood in diagnosing malaria. And the difference is almost 20%. So your chances of picking up malaria will be much higher if you use a fingertip capillary blood rather than venous blood. And especially it is important when the parasite count is low. So always insist to your lab to do a peripheral smear through a fingertip method and not using the venous blood. Now various dipsticks are available for falciparum as well as for Vivex. You should be aware of some interesting facts about them, that they are very helpful because they do not require special training. Anybody can do these tests, so the reliability is good, especially so for gold standard for falciparum malaria. But for Vivex, it is doubtful. So if you see here, the thin smear chances of how much parasite you require is 200. For thick smear, you require just 20 parasite per cmm. And for PCR, you need just 0.05, but we hardly ever use PCR. Now, few words about G6PD. My suggestion is I always try to get done my all patients G6PD and write down on the front of the file G6PD deficient or not deficient. So in case of fever, I can use quinolones and other drugs freely. So all family physicians, what they should do is whenever you get a new patient, always ask him to do a G6PD when he's healthy and write down on his file paper that his G6PD normal or deficient. So it will be very helpful when you are treating a fever patient. As we know that primaquine will become a very important drug for Vivex as well as for falciparum. And if you do G6PD during hemolysis crisis, then it may become negative, falsely negative. So it is always better to do a G6PD along with MP-RMED before starting any treatment, so you don't miss the G6PD deficiency. Now we move on to typhoid. And what is the role of Vidal, typhi dot, and blood culture for diagnosis? Again, for typhoid, the only gold standard test or very sure test is just blood culture, nothing else. Although we are doing a lot of Vidal and so many tests, but blood culture is the most important thing, and it should be offered whenever you are suspecting a typhoid fever. In first week, only do a blood culture, then the success rate will be 90%, it will pick up. If the patient has come in second week, then chances will be 75% to pick up the diagnosis. And if patient is coming late or already on antibiotic, then you should go for clot culture or other methods. About Vidal, honestly, I do not trust at all on Vidal test. I never get it done. And remember, Vidal is not recommended by WHO. And I see a large number of patients in Mumbai, especially, where a large number of people are wrongly labeled as enteric fever because of false positive Vidal test. And I say that Vidal is positive more in other diseases than in typhoid, because in enteric fever, it becomes positive after 2 weeks. By that time, either patient has become all right or he's died. So Vidal is a useless test, and I feel it should be banned by Indian government. And the only way, if you want to diagnose enteric fever, is first is clinical judgment. Any patient who has got a continuous high-grade fever where dengue is negative, other tests are negative, think of enteric fever, do immediately send for blood culture before starting antibiotic, and you get a correct diagnosis, and you come to know that which drug is best to treat these patients. Few words about typhi dot tests. Again, these tests are not recommended by WHO. Only few countries are having these tests. And I have seen in our day-to-day practice that large number of other diseases, typhi dot tests come positive, especially in tuberculosis. All TB patients, they have typhi dot positive. So it is again a useless test, and I do not ask for it. Other tests which can help you in diagnosis typhoid is mild elevation of liver enzymes, and you can get anemia. You have a high ESR, thrombocytopenia, and lymphopenia. So the most important test is blood culture, and then Vidal becomes useful only after 2 or 3 weeks if you want to retrospectively diagnose a enteric fever. Now we come to diagnosis of dengue. At any time, if you feel I am crossing my limit, you can ask me to, I will stop it. Okay. Diagnosis of dengue. About dengue diagnosis, you have to do a CBC, which will tell you about low white cell count, low platelet count, positive tourniquet test, res hematocrit, as I told you. ESR is usually high or normal, and liver function tests are usually abnormal. And though the confirmatory test is by virus isolation, and that is or viral antigen NS1, which is can detect in very few hours you can detect. PCR is the most reliable test. So during first few days, if you want to diagnose, then dengue NS1, which is dengue non-structural protein 1, is the most diagnostic. It may remain positive 8 days as 18 days, and this has really helped us a lot. About IgM and IgG, if you see, IgM usually becomes positive only after 1 week. By that time, patient has already become all right, so it is useless. Similarly, IgG becomes positive after 3 to 4 weeks, so again it is useless. Now you get some reports where from beginning IgG is positive or IgM is positive. In that case, it shows you that patient had already in the past it has suffered from dengue fever. But if you want to diagnose acute dengue fever, then you have to demonstrate NS1 positive or PCR positive. Now, remember, as I told you, that most of the febrile illnesses which we get in India, SGPT is always marginally elevated. Do not diagnose anybody as a jaundice, because I have seen many patients dying just because of this. They thought it is jaundice and they went for Matrava and all those things, and the patient died because of falciparum malaria. So any SGPT which is less than 300, think of all other causes rather than viral hepatitis. Now, a few words about leptospirosis. We do get leptospirosis very often, especially if patients coming from Konkan region and those who are coming from western suburbs from Bhayandar onwards till the Dahanu. We get a lot of lepto patients. In lepto also, the diagnostic problems are there. If patient comes in first 7 days, always go for RT-PCR, which is very, very reliable and done in all good labs in Mumbai. So that will confirm the diagnosis. Now, IgM and IgG, I have seen they are not usually positive. So in lepto, whenever we diagnose on other parameters like patient's history and other supportive evidence. Like, for example, we always have a high WBC count, elevated ESR. Patient is usually having anemia, low platelet count, urea nitrogen creatinine is usually elevated. And the most striking is most of these patients have a high CPK. So whenever I think of lepto, I always ask for CPK. If CPK levels are very high, then most likely you are dealing with leptospirosis. Similarly, if a patient's bilirubin is raised, say 3, 5, 6, and SGPT is not raised, then always think of leptospirosis. CSF analysis can be positive for a long time and can be done in a patient where diagnosis was a problem. Other investigations which can help you in diagnosing the leptospirosis, chest X-ray, especially after the August 2009, I think, when the Bombay was flooded. After that, we had a lot of pulmonary lepto, where patient used to present as a mild cough and a small patch of pneumonia, which deteriorates very fast, and patient goes into ARDS and they die. So chest X-ray should be done in all patients where you're suspecting the leptospirosis. Now, chikungunya, still we are getting almost in a month, I get 8 to 10 patients of chikungunya every month. And I have seen that patients are not properly diagnosed, not properly managed. And still the awareness among the family physicians and doctors is very poor. And if you have a patient who has got a sudden onset, where patient can tell you the date and time that I slept very well and woke up in the morning where I could not stand, then think of chikungunya in our country, and especially if platelet count is low, then that further confirms the diagnosis of chikungunya. Now, other diagnostic methods which are available, ELISA methods and molecular diagnostic, they are usually not reliable, not available. Only important test I have seen is again RT-PCR, which becomes positive in first 7 days of chikungunya, and it is available in Metropolis and many other labs, and which can surely diagnose the chikungunya. While IgM and all, I have seen they become positive only in few patients, and in that case, you think that probably it is not chikungunya. So whenever we are thinking in terms of chikungunya, the most helpful thing is position of the patient. They usually come left. It is why it is called as chikungunya. Chikun means jhuka hua aadmi. Chikungunya means jhuka hua aadmi. So backache, sudden onset with acute febrile joint involvements in a patient who has sudden fever. Fever usually lasts in chikungunya for few, say 1 day or 2 days. Usually fever doesn't log, and CRP is very high. This is how I diagnose chikungunya. So with this, I finish my talk. And if you have any question, please feel free so that I can answer those questions. Thank you. Thanks a lot. And sorry for the inconvenience caused to all of you.
Thank you, Dr. Pardawala. Thank you very much.
Any questions?
No questions in the chat box. Not yet.
Everybody's tired?
Okay, thank you.
Thank you. Thanks a lot.
Okay.
Thanks to whole IMA team for this wonderful CME.
Okay. Dr. Kashyap?
Good afternoon, all. I would like to thank our speakers for today's webinar, Dr. Jatin Kothari, Dr. Praveen Banodkar, Dr. Rohan Chaudhary, Dr. Abhida Shah, Dr. Pardiwala. I also thank our knowledge partners for the day, Apollo Hospital, Sanofi Healthcare India Private Limited. I thank Dr. Kajal Ahuja, Assistant Director, IMA CGP, Mumbai Sub-Faculty, for conducting this webinar smoothly and efficiently. A big thank you to Dr. Girish Rajadhaksha for being MMC observer for today's session. Last but not the least, I thank you all delegates for participating in this webinar in large numbers and making it a grand success. Thank you very much.
Thank you very much.
Thank you all. Thank you, Dr. Pardawala. It was really a nice presentation with
Thank you, sir. Thank
108
you.
slides.
In the end, you managed.
So we should keep a dedicated CME on only fewer. Give me 3 hours, I will explain all the diseases.
Yes, yes.
Sure.
We know that, sir. That's why we always, whenever we want to listen from you, we always approach you.
I know. Thank you. Thanks a lot for giving
You've
me.
got a passion of teaching.
Thank you, sir. Thank you.
There are always many take-home messages for everyone who attends. Thank you. Thank you. Thank you all.
Thank you.
Thank you.